Every second, doctors make life-changing decisions, technology enhances human skill, and science pushes the boundaries of what's possible. But one question remains. What lies behind modern urology? It's not just procedures. It's not just diagnosis. It is a field transforming quality of life, restoring dignity, and redefining longevity. Urology saves lives. Innovation improves outcomes. Knowledge becomes care. But what defines the future? Technology alone, or the expertise behind it? Today is not just a medical event. This is a moment of progress. How will we shape healthcare? Through innovation or tradition? Through speed or precision? Through routine or excellence? Central Asia is entering a new era of medicine. And here, solutions are born that will define patient care tomorrow. Welcome to Central Asian Endourology Congress 2026.
Good morning, distinguished guests, respected professors, dear colleagues, and participants. Welcome to the Central Asian Endourology Congress 2026 in Tashkent, Uzbekistan. It is an honor to open this Congress and welcome leading experts, surgeons, and medical professionals from across the region and beyond. Today, around 5 billion people worldwide still do not have access to safe surgical care, making the advancement of minimally invasive fields like endourology not just innovation, but a global necessity. As we come together for the second year in a row, we are proud to see how strongly this platform has grown. This year, CAEC 2026 welcomes 45 speakers from 23 countries, highlighting its expanding international character. Over the next 2 days, the Congress will unite science, practice, and innovation in endourology. The program includes advanced clinical cases, modern technologies, and current treatment approaches presented by outstanding specialists. On behalf of the organizers, thank you for being here and for being part of CAEC 2026.
Good morning, ladies and gentlemen, dear guests, colleagues, partners, and participants. Welcome. Thank you for joining us today here. We are very pleased to see you. It is especially meaningful that this Congress is being held once again through the collaboration of Akfa Medline University Hospital and Central Asian University, continuing to bring together the professional community in Tashkent. To begin our program, it is my great privilege to invite to the stage First Deputy Minister of Health of Republic of Uzbekistan, Mr. Alisher Babayev.
Assalomu alaykum, hurmatli anjuman ishtirokchilari, muhtaram xorijiy mehmonlar, qadrli olimlar va tibbiyot sohasi vakillari. Barchangizni Markaziy Osiyo endourologlarining 2-kongressi ochilishi munosabati bilan samimiy muborakbod etaman. Eng avvalo, anjumanimizda ishtirok etish uchun mamlakatimizga kelgan xorijlik professorlar, xalqaro ekspertlar va sherik tashkilotlar vakillariga samimiy minnatdorlik bildiraman. Sizlarning bugungi ishtirokingiz yurtimizda tibbiyot fanini rivojlantirish, innovatsion amaliyotlarni joriy etish va umumiy maqsad inson salomatligini mustahkamlash yo'lidagi hamkorligimizga qo'shimcha kuch bag'ishlaydi. Ushbu nufuzli xalqaro anjumanni qadimiy va navqiron Toshkent shahrida o'tkazilayotganligi mamlakatimiz tibbiyotining jahon hamjamiyati bilan chambarchas bog'lanib borayotganidan dalolat beradi. Muhtaram prezidentimiz ta'kidlaganlaridek, inson salomatligi davlat siyosatining eng ustuvor yo'nalishidir. Bugun davlatimiz sog'liqni saqlash tizimini tubdan isloh qilish, uni xalqaro standartlar asosida rivojlantirish va aholiga sifatli zamonaviy tibbiy xizmat ko'rsatishni ta'minlashda alohida e'tibor qaratmoqda. Ta'kidlash joizki, birgina 2024-25 yillarda respublika ixtisoslashtirilgan urologiya ilmiy amaliy tibbiyot markazi va uning filiallari davlatimiz tomonidan $14,7 million tibbiy uskunalar bilan jihozlandi. Endourologiya bu zamonaviy tibbiyotning eng tez rivojlanayotgan, yuqori texnologiyalarga asoslangan strategik yo'nalishlaridan biri bo'lib qolmoqda. Mamlakatimizda xususiy sektor uchun yaratilgan qulay shart-sharoitlar sababli oxirgi 10 yilda har bir viloyatda yuqori texnologiyali endourolog amaliyotlarini bajarayotgan bir necha klinikalar faoliyati yo'lga qo'yildi. Bugungi nufuzli anjumanning xususiy klinika tomonidan tashkil etilishi ham bundan dalolat berib turibdi. Mazkur kongress ilg'or ilm-fan yutuqlarining tibbiyotda keng joriy etish, innovatsion texnologiyalar almashinuvini ta'minlash va chet ellik hamkasblar bilan tajriba almashish hamda xalqaro hamkorlikni yanada mustahkamlashda muhim ahamiyat kasb etadi. Alohida ta'kidlash joizki, ushbu anjumanning Yevropa urologlari jamiyati bilan hamkorlikda tashkil etilishi O'zbekistonning xalqaro tibbiy maydondagi nufuzi ortib borayotganidan dalolat beradi. Bugungi globallashuv davrida tibbiyot sohasidagi taraqqiyot hech bir davlat doirasida cheklanib qolmaydi. Ilm-fan, tajriba va innovatsiyalar almashinuvi barchamiz uchun umumiy maqsad. Inson hayoti va salomatligini muhofaza qilish yo'lidagi birlashtiruvchi kuchdir. Sog'liqni saqlash vazirligi har doim ilmiy tadqiqot ishlarini, yangi tashabbuslarni, sohada innovatsiyalar joriy etilishini qo'llab-quvvatlaydi. Muhtaram ishtirokchilar, barchangizga mustahkam sog'liq, samarali faoliyat va ushbu anjuman ishlariga ulkan muvaffaqiyatlar tilayman. Rahmat.
Thank you, Mr. Babayev, for your inspiring and thoughtful address. And now, please join me in welcoming co-chairman of the Congress, Dr. Laurian Dragos.
Thank you very much. It's again a privilege to be here. It's an honor. It has been a journey building this thing, and I am extremely, extremely proud and grateful to all of you for being here and being a part of this journey. I only have 5 words: friendship. Everything that you see here started with friendship, and it's my privilege and honor to have Azim as a friend. He has done an amazing job. Second, and very important, is vision. I remember even now, a few years ago, envisaging all this with him and thinking, yes, maybe this will be possible. Third word, work. For all the young guys, I know the world that we live in today may look like work is not worth it anymore. But look, we are here because of extremely hard work that all the team has put together to build this and to arrange this. And the humankind got where we are by working. The fourth thing is passion. Love what you do. You can't go anywhere, you can't get anywhere without the passion and love for what you do, for your job, for helping your patients. And medicine will remain a job that is driven by passion. And the fifth thing is collaboration. We can't move forward. And again, the humankind is based on collaborating. This is what brought us from the initial stage to where we are today. Remember this, in this extremely troubled world, we still need to work together. We still need to collaborate. It's the only way to go forward. Thank you very much. I hope you'll enjoy the Congress. It has been an incredible journey and a lot of hard work. And, you know, the organizing team deserves all the applause. Thank you.
Thank you, Dr. Dragos, for your valuable insights. And now it is my distinct pleasure to invite Chairman of the Scientific Society of Urologists of Uzbekistan, Professor Farhad Akilov.
Добрый день, уважаемые коллеги, дорогие друзья. От имени Республиканского научного общества урологов разрешите приветствовать вас на втором, ставшем уже традиционным, Центральноазиатском эндурологическом конгрессе, который проводится под эгидой Европейской ассоциации урологов. Узбекистан всегда был пионером в области внедрения современных технологий. И если сейчас оглянуться назад, то прошло уже практически 40 лет с тех пор, как в нашей клинике под руководством нашего учителя, профессора Арустамова Дмитрия Львовича, была выполнена первая эндурологическая операция, затем первая трансуретральная операция, первая литотрипсия в Узбекистане. Сегодня у нас есть весь спектр малоинвазивных эндоскопических вмешательств, включая роботические. Данный конгресс стал хорошей площадкой для обмена инновационными идеями и передовым опытом. Поэтому еще раз разрешите приветствовать вас в Ташкенте и пожелать успешного проведения нашего конгресса. Спасибо.
Профессор Акилов, я попрошу вас остаться на сцене. Now, I invite to the stage a person who has also played a key role in making this Congress possible, Mr. Azamjon Tursunkulov, CEO of Akfa Medline University. And with great honor, we would like to welcome to the stage Dr. Peter Alkin. For the special ceremony, to confer to Dr. Peter Alkin the title of Honorary Professor of Central Asian University. And also we would like to invite Dr. Muradjan Akhrarov, who is the Dean of Medical School of Central Asian University. Ladies and gentlemen, your warm applauses, please. Dear guests, please let us join once again in congratulating Dr. Peter Alkin on this distinguished recognition.
Well, dear friends, you could see that they helped me to get the hat on. You could see that they helped me to get the robe on. And I can tell you that I started the whole business 50 years ago, but without that somebody helped to progress with it, I wouldn't have reached this position, because everywhere in the world, people were adding some new steps, some changes, and that kept the technique I have initially invented alive. So the hat, the professorship, My robe is all thanks to you. Thank you all.
Thank you very much, Dr. Alken. So now, we would like to wish you a productive and successful Congress. And now it is my great pleasure to announce the beginning of the first day of our Congress. Thank you very much.
Can I have the... Yeah. Good. So, Professor, many thanks again for everything you've done. It's a privilege and an honor to have you with us again. We've all learned from you, and we will continue to learn from you. We are going to start the Congress today with, it's an Endourology Congress, so lasers will be always with us, and lasers are probably at the core of endourology. But do we have the perfect laser in endourology at this stage? Let's have a quick journey through what's going on, and we'll decide together. Coming from Cambridge, I live in an almost Harry Potter universe, and I would invite you all to visit me there. You'll see the amazing, 1,000 or 800-year-old buildings still there, and it looks indeed like in the movie. But when I think about this laser specifically, I always compare it with the old wizard. And most of you should know this is the holmium laser, the laser that has been with us in endourology for almost 40 years now, and it is still delivering. And this is how a holmium laser looks on the inside, how it's built. It is basically a lamp laser with a holmium doped crystal, and it's not a very complex, from this perspective, construction if you think very schematically. However, if you discuss with the laser engineers, things are very, very interesting and complex. We don't have time to go through all these details, but these were the first generation of lasers. Okay. Sorry. As you can see, small machines, not very large, not occupying too much space, but not being able to deliver a lot of power. It's what I would call the low power holmium lasers. Then the second generation included larger machines with more power. But how are they built? And this image should be more familiar to you when we talk about the current holmiums. How are they built? By putting together multiple cavities. It's not one as initially, but you can put together in a laser, a medical holmium laser machine up to 5 cavities. Each cavity is able to deliver around 30 watts. So there is a limitation, a physical limitation in how we build these machines, and we can't really efficiently put together more than 5 cavities. It means that more or less the power of a holmium laser, a high power one, will stay around 150 watts, and this is what we have currently on the market. But then we learn more, and we continue to learn more. So we learn that actually the length of the laser pulse is very important. It's not just the power of the laser itself. It is important because we use the lasers in treating very delicate things. How is it important? The shorter the pulse, the bigger the effect. And I think I have a nice video here, and you'll see the difference. Exactly the same laser settings, but when you use a long pulse, you'll have less hit, less retropulsion, smaller fragments. When you use a short pulse, you will have a bigger hit, larger fragments, more retropulsion. So if you think at the laser energy, which is joules, remember the J sign, just think of a J as a hammer. It is the same hammer, but if you hit with it like this, very shortly, or if you hit with it like this, you will get different effects. Now moving forward, and this is a slide that probably if you remember only this slide from all my talk, I'm really happy, because it is very important for the basic thing for us using lasers is that what do we need to achieve and how we get things. When we treat stones with a laser, the only thing that actually matters in the size of the fragment is the hammer, is the energy. So if you want small fragments, you will have to get, sorry, let me see if this one works. Yeah, perfect. You will have to get a lower energy and a longer pulse. If you need to get larger fragments, you'll have to get larger energy, more energy, higher energy, and a shorter pulse. Okay? Small hammer, small fragments, large hammer, large fragments. What's the hammer? It's the J, the energy, not frequency. Frequency, it means how frequently I'm hitting with a hammer. It doesn't affect the size of the fragments. So when you say dust, I want to create dust, I mean small fragments, you just want to use a smaller hammer. How frequently you use that hammer, it may or may not increase the speed of the process. So then the fourth generation of lasers is when we discovered the pulse modulation. Not us as endourologists, but the laser physicists explained it to us and started to use it in lasers. And basically it's a way to modulate that hit. Instead of hitting like this anymore, now you hit something like this in a way to deliver the energy better and more straightforward and use the laser energy better. This is a nice video. You understand the concept of the Moses pulse modulation. Basically, you use the first part of the laser pulse to send the second part through the void that is created. And that hits the target without pushing the target. So less retropulsion, smaller fragments, better dusting if needed. That was the fourth one. I'm going to skip a lot of slides here because we need to stay in time. But this kind of pulse modulation can be done in as many ways as you want. We don't understand the clinical effect, because the big problem with lasers, and something you need to remember, is in lab they work perfectly because they are always kept at the same distance from the target. But we have a big issue in real life. We can't keep the same distance, and then the laser energy is absorbed, and all the other effects, all the modulation becomes, useless because the energy doesn't get to the target. So that was the force, and obviously other companies have developed similar technologies. So if you want, with a whole mu, if you want less retropulsion and smaller fragments, then you use lower energy, longer pulse, and a pulse modulation technology. Let me see. But then there was what we thought is the Harry Potter of lasers, and that was the TFL. The thulium fiber laser is built differently. It doesn't have a crystal, it has a fiber inside, and it's a diode laser. Multiple machines have been put on the market, but there are currently only 2 real manufacturers. All the others are just using their machines. There are big differences, but in this slide, I'm not going to insist on it. I'm just going to show you this slide, which was the next thing about laser physics that we started to understand, and it's incredibly important, is basically the peak power of the laser. Though you would say, I have a 100 watts laser or 60 watts laser, that is not what the power, that is the average. So the peak power, you need to think of it as the area under the curve. So under the green curve, That's the peak power, that's the area. And with the holmium lasers, you will have extremely high peak powers, going up to 15,000 watts. Compared to the TFL, the maximum peak power will be around 500 watts. This is all the time dependent on the length of the pulse, because you have to squeeze that power in a longer or shorter pulse. But the big peak power of the holmium is very difficult to tame, and it won't allow you to get very easily very small fragments, because though you use a theoretically big hammer, a small hammer, it will always have a very big hit. What would be the benefits of the TFL? Less retropulsion, because the peak power is much smaller, finer dust because of the same thing, and it also because it gets absorbed differently, has a better coagulation than holmium. These are all studies showing or confirming or more or less this. What would be the thing that the TFL can't deliver is probably less efficient with fragmenting. Because of a low peak power, there will be less efficient fragmentation. And the third generation, the last generation of TFLs may help to achieve that as well. So they are trying to improve it. Now, the Harry Potter family is large. There was another laser that we are using now, and that is the pulsed thulium YAG. Pulsed thulium YAG means we don't have a continuous wave thulium YAG, thulium crystal laser, but the emission is modulated from continuous to pulsed. There are a few advantages, and I did put here something. This laser, compared to the big holmium machines that require lots of energy to cool down, is back to a water cooling system. It means smaller machines compared to the big holmiums and less noise in your theaters. Also, you can use a single-phase electrical socket, not a three-phasic socket like the ones that you will need for a big high-power holmium. Where do we stand in terms of characteristics? We stand more or less in between the two lasers, and the peak power is also in between. It means that it will be taking the best out of the both worlds. Now, just for you to understand, the bubble, this is almost like a TFL bubble. This is the standard holmium bubble, and the pulsed thulium YAG stands in between them. So it has efficient fine dusting, low retropulsion, good fragmentation efficiency, and is capable of dusting all fragments. There is also another one. So the most recent one is basically a holmium laser that tames the amazing peak power of the holmium and delivers it in a way that is almost similar to TFL. What would be the advantage? You've got excellent fragmentation from the holmium world, but also almost similar capabilities of creating fine dust like the TFL, the thulium fiber. And excellent, lots of modulation possibilities. Actually, to be honest, quite a few of them. And for someone who's not an expert and doesn't understand lasers perfectly, you may get lost in all these combinations. But the way that this machine can be calibrated is fantastic. This was an important slide because it basically shows you how the peak power, the huge peak power of the holmium, this thing, is tamed and kept in more or less in the 500, 600 watts range of the TFL. But it's not a linear effect. It's basically like putting a huge angry tiger in a cage. And with this one, that's going to be my last slide. I'm trying to summarize, what are the characteristics of the current lasers and give them some stars. And you can see there, none of the current lasers have the 5 stars that we want, but we are getting there. So my response to the initial question, have we found the perfect 5-star laser in endourology? Not yet, but we are getting very close. thank you very much. Again, it's amazing to see the room full. I hope you'll enjoy the conference. I'm looking forward to it. I'm looking forward to learn from what we will discuss these days. Thank you. And now we will move to theaters, and I'm very happy to have Nariman and Shukrat with me, with co-chairing this session, and this is the case. I think everyone can read it, but I'm just going to briefly present it. A young male patient, stones in both kidneys were identified, and as you can see, in the left ureter, there was also a stone and obviously subsequent hydronephrosis. From his history, he was admitted in 2008 and had left-sided ureteral lithotomy, and then later 2021 had ureteral lithotripsy and PCNL again on the left-hand side. We are very lucky and privileged to have in the room, operating in the theater room, Professor Olivier Traxler from Sorbonne University, from Paris, who has been a mentor and a good friend to many of us here in the room, and to whom we owe a lot in terms of ureteroscopy and development. So can we have transmission to the operating theaters, please?
Lauriane, can you hear me?
Yep.
It seems, huh? Okay, good. Good morning, Lauriane. Good morning, everyone. It's a pleasure for me to be back. I would say to be back to Tashkent, Uzbekistan. I'm very happy to be here with all of you. And as you described, the case, Lauriane, it's a young male. He had some stones into the ureter. So originally, a semi-rigid ureteroscopy was performed, but he has still some residual fragments, so some of them are blocked in the distal ureter. He has also some stones just below the UPJ, and probably some stones also into the kidney. So I think it's an excellent indication for retrograde ureteroscopy. For this case, I will use exclusively flexible ureteroscope. I will not use a semi-rigid first. That's the technique I'm using. But of course, you can switch and you can use both equipment. There's no obligation to do it by flexi. So what did we do just before we were online? We did the cystoscopy. We removed the double J. It was not encrusted. So we exchange with the safety guide wire. It's actually in place. I guess you can see the X-ray picture. And then we engage the urethra. So we are actually into the bladder with the flexible ureteroscope. We're using today the huge med. This one is the 7.5, but as you know, it's also possible to use the 6.3. In terms of setup, you know this setup, it's a very regular, very simple one. Patient in the lithotomy position, X-ray control. We use a table just beside us with my assistant to put all the equipment. The laser unit is there. Today we are using the holmium technology from Quanta. We connect a laser fiber, 200 micron, which is the smallest actually we can use with the holmium technology. And to irrigate just the gravity, 50, 60 centimeters of gravity with saline. And my assistant will manipulate this manual pump just to modulate my irrigation flow. When we need to have extra flow, she will just press this system. So actually we are, as we said, into the bladder. As you can see, you see the ureteral orifice with the guide wire. So now we need to engage. So the technique is not very complicated. We need just to rotate to see the ureteral orifice and to place the ureteral orifice on the midline, 12, 6 o'clock. You see it's actually on the right side of the screen. So I just torque my endoscope to place the orifice on the midline, 12, 6. Then you deflect to put the orifice in the middle of the screen, like now. So I keep this position, and now I push with the left hand, and I'm just in the direction of the ureter, so I can engage actually the ureter. So that's what we call the no-touch technique. This is this technique that we're using when we are making a diagnostic procedure, or if we need to treat urothelial tumor, UTUC. Okay, so let's move. Now we are really in the distal ureter. And look, there is some kind of stenosis now, you see? And that's why the stone accumulate, probably, and they didn't evacuate. So we need probably to proceed with some fragmentation or dusting, just to make the fragments smaller, and before we can proceed to the kidney, okay? So you see all the fragments, and it looks like a calcium stone, mainly calcium oxalate dihydrate. Even it looks like a mixed one with probably some monohydrates. You can even go up to have a look in the upper part, just to check very quickly, and then we will be back to the distal. Yeah, you see the stone, and it's a typical calcium oxalate dihydrate, meaning that the main problem in terms of metabolic is probably hypercalciuria, something to be checked after the surgery. So let's go to ready. So you see my laser fiber.
Yeah,
Yes.
Olivier, good day. This is Nariman from St. Petersburg. It's quite an impressive case. I mean, that's with this kind of stone burden, did you consider anything else like semi-rigid uroscopy for the ureal part?
Yeah, sure. You can combine. You can use a semi-rigid. It's ready now. To be honest, in my practice, I'm not using any more semi-rigid. I'm doing everything with my flexi. Of course, in this case, you can also do some kind of basketing if you prefer. I prefer to dust in very tiny pieces. And then we are using this Venturi effect. You know, the Venturi effect, it's not only for mini PCNL or PCNL. It works perfect with flexible ureteroscopy, you will see. But we need before to decrease the size of the fragments. And then we will evacuate them with no basket, just using the Venturi effect. I will show you that. But it's up to you. If you prefer, if you feel more comfortable with the semi-rigid, use the semi-rigid, no problem.
Thanks. Olivier, you have so many tiny pieces. I mean, what about suctioning them? I mean, even without not touching them.
Sure.
Can you have an ability to use a fence?
Absolutely, that's another possibility. I agree, but we are really in the distal. It's maybe 1 or 2 centimeters from the ureteral orifice, but probably feasible also. I agree. You know, I like to save my equipment. I don't like to use too many equipment. So I try to, I'm a bit surprised by the effect. I'm using actually 0.9, which is a lot. But I'm a bit surprised the effect is not exactly what I expect. You know, I was expecting to have a much better effect actually. It looks okay. We already checked the blast shield from the laser units. One looks okay. But you see, it's not very impressive, huh? I must say. 0.9, and I'm using 10 Hertz. So it's 9 watts. Huh? We keep low power, less than 10 watts.
I actually
also
wanted to
less
ask
than
about
10
your laser
hertz.
parameters.
Yeah.
And the
short
goal
pulse.
here, so it is not to dust, but to fragment.
Yeah, sure. The idea is to have tiny pieces, and then using the Venturi, it's supposed to pass the stenosis to evacuate spontaneously. I will show you that, okay? No problem.
While you're doing this, Olivier, so just to explain your strategy, it's likely that you're not going to waste time to try and remove those fragments at this stage, but get them at a smaller size and then pass with this very thin ureteroscope that allows you to just pass above them and treat the stones upwards in the kidney. Am I correct?
No, Lorian, you need to evacuate everything from the distal before you proceed. Otherwise, there's a big risk that if you leave the fragments in place, there's a big risk that you will block the endoscope because of the friction with the fragments, and then you will be in big trouble because you cannot remove the scope. So don't do that. The safe message is clean the ureter. Yeah, pump. So no, a little bit more.
That was exactly the comment
you
I
need to clean
expected.
distal before you can proceed to the kidney. Otherwise, there's a really big risk, believe me, to block. It happens with some of our colleagues that you maybe know, and then it's a disaster because the scope is completely stuck. Okay? Yeah?
I was just trying to tell the audience, don't fall in this trap. So this is what, like Olivier said, exactly what happened. There was a case in the literature when the scope remained completely stuck in the ureter. And they...
Yeah, I had one. You never leave anything behind your scope. I mean, you cannot go further if you're not dealt with something below. Olivier, what about the pressure?
Yeah, right.
Does it concerns you? Because the procedure will be, I mean, quite long enough. We have a high stone burden. Do you utilize, for example, ureteric catheter, a small one, which can drain the kidney, or what is your behavior? I mean, how do you control the pressure?
You know, first we are using, if we don't manipulate the pump by my assistant, we are using gravity, it's more or less 50, 60 centimeters. Usually I use 40 to 50 centimeters. So the maximum you will reach, if you don't manipulate the manual, is 40, 50. And it's a column of water. So it's considered like low pressure, even it's not low, because the normal pressure into the kidney is 10. So 40, even you are thinking it's low, it's not so low at the end, okay? You are supposed to don't generate intrarenal reflux if you respect 40, 50, but we don't know exactly. When we manipulate the pump, of course, when we accelerate the flow, we also increase the pressure. So this is something you can feel in the pump. You can teach your assistant if it's too hard or not. You feel the pressure. So something you can teach your assistant to minimize this feeling. It's of course subjective, but this is, I think, a good trick to minimize the pressure. If you really want to minimize the pressure, of course, access sheath, we know it's a very positive instrument to decrease the pressure. And if you are using the fans, again, you are supposed also to minimize the pressure. But again, when you're using the fans, you're using very high negative pressure to aspirate, and you're also using high pressure to irrigate. So very complicated to tell the people that you control the pressure. To control the pressure, you need to have a pressure sensor. And that's the only way actually to know exactly what you are producing.
Thank you,
It's an excellent topic, but I think we are discussing a lot regarding pressure today, not knowing exactly what we are doing, to be honest.
Olivier, I have a question aside the surgery. I was curious. For example, we have some Chinese new endourology device. How many years will it take to appear in the French operating theater? CE mark, has hospital procurement. How long will it take until it will appear in France
you need
legally?
To have this new pump, you mean?
Yeah, maybe funds or something, or some other technology.
Yeah, you know the
from the
you know the problem
regulatory
in
standpoint.
Europe actually. Yeah, you know the problem actually to get the CE mark. It's very long process now. I do remember in the past we were all the time the first in the world to validate instruments and to test it before the American with the FDA, but now you know the new regulation with the MDR regulation is very, very demanding and making this approval much longer compared to Asia or even compared to FDA actually. So it takes a long time.
It takes 2 years. Yeah.
3 years, my
Yeah,
goodness.
2 years.
It's more or less the same, huh, probably.
Same.
More or less the same, yeah. And it's not a problem. It's like this, you know. Again, in the past, you know, in Europe, we were all the time the first to test a new technology before the Americans. I do remember so many equipment that we used before the American. Now it's the opposite. We are the last. And it's a pity, I must say, because we really would like to use all these new technologies, but
yeah, totally agree.
That's the European route, you know. And it's true that actually most of the innovations are coming from Asia. Most of the company, we have fantastic leader in Asia actually. So everything looks excellent in Asia, you know. Company, technology, key opinion leader, fantastic. Okay.
Olivier, so talking about this, you're using a scope made in Asia. So how do you choose your scope at this stage with the huge variety of scopes available on the market? What are the characteristics that you are looking for when you choose the scope that you're working with?
Yeah, I think the two main criteria actually for me, the main one is what we call the maneuverability. I'm not very impressed by the vision. The quality of vision is more or less the same for all of them. You know, they are using more or less the same sensor, same equipment. So in terms of quality of vision, I don't think you can make big differences. So for me, it's not very important. But the most important one is the manipulation. It means the torque, for example. You know, we need to have a fantastic torque, one by one. And we can see some differences, really big differences between the different companies. So what I'm testing first is the maneuverability and the durability. I want to have something robust. I don't want to have any problem in terms of breakage into the kidney. So it must be robust and with an excellent maneuverability. And then for me, the second and it goes a little bit together. The second criteria for me actually is, of course, the cost. In terms of size, you know, most of the company produce 7.5, even 6.3. You know that many companies are coming with 6.4, 6.9, 5.9. So the size actually, again, is not a big criteria because most of them are small enough. So at the end, the price is also very important because it's very competitive. We are using more and more flexi, so we prefer to have something not too expensive. But the main one is really maneuverability.
I think we actually need even smaller scopes than 6.3.
We need, you think we need less than 6.3? Yeah, close to 6, I think looks perfect, you know. I don't know if we really need to move more and more regarding the size. Actually, if you have something around 6, you know, with the 6.3, I'm using the 6.3 from UGMed every day, and that's my standard scope actually. And I must say that in terms of ureteral access, we have a 98% success, 99. You know, it's, if you can put a double J, 7 French double J, you can put the scope. So, but of course, if we're able to produce something a bit smaller with the same characteristics, same price, I would be more than happy to use even less than 6. Problem is also that if you compare, for example, the torque of the 6.3 from UGMed with the 7.5 from UGMed, you can feel a bit small differences. You know, the 7.5 is probably better for the torque. Even the torque of the 6.3 is excellent, but you feel some difference. So if you decrease the size, the risk is to have a worst torque effect. So it's a compromise, as always. Endourology is a fantastic example to talk about compromise in all aspects.
Oh,
Okay.
we have approximately 5 to 9 minutes left from the live transmission. If you want to make any additional comments, or if you want to talk us through a bit the next steps in terms of strategy, because it's unlikely that we will be able to be with you until the end of surgery.
Okay. So again, we proceed like that. As soon as I think that the pieces are small enough, pump up a little bit. Okay, good. Again. Yeah.
Olivier, I have one question.
We'll be able,
which is quite interesting, would be to the audience. What is your upper limit in terms of stone volume for RIRS? I mean, above which one you would say your resident stop it, and proceed to PCNL? But not the diameter, of course, the volume.
Yeah, the volume. You know, I all the time when I'm teaching my resident, my fellow, when I'm giving a talk, I respect the guidelines. You cannot tell the people it's a 6,000 cubic millimeter. You can go with flexi, no problem. No, I think the maximum we can recommend, according to the guidelines, is 4,000 cubic millimeter, because it means 2 centimeter stone. 4,000 is the max, because it's an equivalent. It's the volume of the maximum volume for 2 centimeter. So if you consider the guidelines telling the people up to 2 centimeter you can go, if it's a real 2 by 2 by 2, it means 4,000. But it doesn't mean that because the guidelines are telling you can do it, that you can do it. You need to know what you can do it personally. So you need to evaluate your personal performance, and according to that, you can do it. For example, for me, 2 centimeter, 4,000 cubic millimeter, when I'm using my thulium fiber technology, I need, that's an average, I need 1 hour, 40 minutes.
Olivier,
which for me,
do you think fans will change your upper limit?
Sure. All the system using section today, of course, the fans is the best example, gives the possibility, the opportunity to do more volume in the same period of time, absolutely. But again, we need also more evaluation, very strict and evaluation regarding the fans. You know, we are making a review paper actually regarding the fans, regarding the origin of the data, who is publishing, and the quality in terms of evidence-based medicine. It seems it's very low actually, I'm sorry to say. So this is a fantastic equipment. This is a step in terms of section, but we can say that section concept will change, of course, the guidelines in the future. I think there's no discussion on that. Huh?
So thank you very much, Olivier. We are going to be with you for 2 to 3
Sure.
more minutes, I'll ask the audience
Okay.
if there's any question for Professor Traxler. Please take your opportunity, get to the microphone. The language should not be a barrier, so you should speak in your own language. Anyone from the room wants to ask anything to Olivier? Yes, please.
Oh.
Emre.
Oh. Sorry? No,
Yeah.
that's fine.
Is it working?
Look, it's okay. No worries. Oh. Again?
Now it's working. Good morning, everyone.
Okay.
Good morning, Professor.
Let's move a little
again
bit.
a privilege to watch you operate. This is Emre. I don't know if you have understood from my voice. Anyways, there is a practice about putting a small catheter into the bladder, especially during longer operations.
go?
Do you think keeping the bladder pressure low helps cleaning these fragments with the Venturi effect? Thank you.
Emre, I'm sorry, but I know
We
it's you,
can't hear
Emre,
you,
but
Olivier.
the sound was very,
Can you
very
hear
low.
us?
So maybe Lauriane, can you repeat? Lauriane?
Yeah, we
Can you
can
hear
hear
me?
you now, yes.
So I know Emre asked some question, but the sound was very low. So can you repeat the question of Emre?
Yes. So basic.
He was
Emre
talking
is
about
gonna
what?
repeat it.
What?
Emre
The
is gonna
bladder
repeat it
to
again.
empty the bladder at the same time, something like
Yeah,
that?
Professor, hello again.
sure.
Good morning again.
Hello,
thank
Emre.
you- Thank you very much for the excellent demonstration as always. My question was, do you think keeping the bladder pressure low during the operation by putting a small Foley catheter would increase the clearing effect with the Venturi?
Exactly.
So is
Yeah,
that like
that's,
a routine
that's
practice?
an excellent point, Emre. That's an excellent point. You're totally right. And if the bladder is full, of course, you have a lot of pressure coming from the bladder on the intramural part of the ureter, and then you don't evacuate so easily the small fragments. You're totally right. We start with an empty bladder, but you're right. You know, when I use my hand to feel the bladder is not full actually. Of course, it's not totally empty, but it looks okay. So the idea, actually, the fragments were small enough for me to move to the next one. I think it moves actually through the UPJ to the kidney. So now we're into the kidney. Let's have a look, see what we need to do. What I
Olivier,
like
just
to
a
do, you know, when I'm
quick
Sure,
comment
tell me.
quick comment from your side, please. You had a larger fragment in the ureter, and your strategy
Yes.
to treat it was a bit different. So can you please explain to our colleagues how we should treat a stone in the ureter in terms of how do we approach it?
Yeah, I think there's two points. You cannot go fast into the ureter because you need to be very careful with the mucosa. You cannot heat the mucosa with the laser. Huh? So use very low setting. It means the energy what you need. Now it's 0.9, so it's not very low energy, but frequency is low. You need to control all the shots on the stone, not on the mucosa. So it means low frequency. Maximum 10 if the ureter is large enough. If the ureter is tight, go with 5 Hertz, 5 pulses per second. Go in the center of the stone. Don't go on the surface because you are in contact with the mucosa. So you go in front, you go into the stone, and from the inside you go external. Doing that, you protect really the mucosa. Very low setting, shot by shot, starting in the middle, going inside, from the inside going outside. If you do that, there's no reason to damage actually no reason to damage the mucosa to generate ureteral stenosis due to thermal damage. Now we enter the kidney. You see that we still have many pieces. So for this case, we will use the. I will proceed a little bit with fragmentation and use the access sheath, the fans, to aspirate the fragments. Huh? But I will.
We have a
start
question
first
from,
with
from the room from Azinjon.
Yeah?
Olivier, thank you for
Sure.
joining our Congress and welcome Tashkent. Thank you for
Hello,
the
Asinjon.
surgery. Hello.
Thank you for the invitation.
Can you give a few advices and the comments about using the X-ray during flexible surgery?
Sure. Again, for X-ray, you need X-ray. If you listen some people telling you you can do it without, I don't totally agree with that. We need to have the X-ray ready in the room, ready to use if you need it, okay? But you need to minimize. You need to minimize this, the use of X-ray, respecting the ALARA concept as low as possible, but it should be there. And no need to check all the time what you are doing, you know. If you proceed in the good way, wait that the stone is completely dust before you make a short control. But again, you need X-ray. For me, it's an obligation to have the system ready, available in the room, ready to be used, but minimize the activation of X-ray, and just to the minimum.
Olivier, we have to leave you. You've done amazing as usual. I would like one last comment from you about the strategy on how you approach stones in the kidney and the difference between kidney and ureter here.
Of course, you know, this case is different because it's multiple fragments. It was already fragmented, so plenty of fragments. We need to treat each of them one by one. But usually it's one stone. So because if one stone, I would not fragment the stone, I will dust, try to do full dusting. You start from the surface and you go to the center. So you minimize the volume of the stone, keeping only one stone if possible. At the end, when the stone is very small, then maybe you can do some fragmentation. According to the volume, according to the stone composition, we are using the fans to aspirate at the same time the fragments, but it's not something we do systematically, and we really analyze the situation. And I think that's the main point for me treating kidney stones. Huh?
Yeah, can you show us the calcium oxalate monohydrate stone that you found very nicely, and then we have to go.
We saw before. Yeah, it was in. Yeah, I think it was not in this one. Huh? No, it's maybe upper.
I think it was in the upper somewhere.
Yeah, it was in
the
very.
For the young doctors to see the difference between.
Sure. Let's go. You see this? It's like an hydrocalyx, and this one. You see the infundibulum is really narrow.
Yep.
I would engage. So good to have the 7.5. Maybe the 6.3 would be even better. So you see, it's a typical one. So why it's so different? Probably because of the hydrocalyx with a huge urinary stasis. Maybe you know that if you develop calcium oxalate dihydrate, the yellow one speculate, if it stays a long time with urinary stasis, it becomes monohydrate. That's the conversion of crystals from dihydrate, which is very unstable, going to monohydrate. It's a typical monohydrate. So probably due to conversion of dihydrate to a monohydrate. It looks typical. And when you see this gray part on the surface, it means that it's a fresh crystals. That's a very recent deposit of crystals. That's why it looks so gray. And by the time it takes the color of the urine, it becomes black.
Perfect. Thank you very
much. Look at the internal structure, typical monohydrate.
It was an excellent opportunity especially for our younger colleagues, to see two types of stones in the same patient. Both of them calcium oxalate most likely, but with a different type of calcium oxalate. I think you deserve a big round of applause. Amazing. Thank you very much for being with us.
Olivier. Thank you.
Thanks. See you soon.
Now we're going to continue with the lecture, and we are very happy to have with us Professor Cevat Tevfik from Istanbul University, who will basically continue the topic on scopes that we've already started to go through with Olivier, and update us on what we have in terms of scope miniaturization in endourology. Seva, thank you very much for being here.
Dear all, dear Azim John and Lorian, I'm really honored to be here with you today. Last year I was on an online talk, and this year I'm face-to-face with you. And as Lorian has mentioned, it's the friendship that starts everything, actually. So we are friends here, and I'm sure that we will be friends in the next years, and we will develop more on these ongoing projects. So friendships starts not only with the urologist, but also with the team of engineers. And when we have the topic going small to win big for the endoscope miniaturization, I had to involve some kind of engineers and companies to prepare this talk. I have conflicts of interest about Endorobotics AI. Is a startup company, but dealing just with software about follow-up of patients. And this presentation has been done by Ahmet, one of our residents, and he has used Notebook LM for some kind of visual effects. So we will talk about a little bit of why do we miniaturize, and what is the ureteroscopy, miniaturization, semi-rigid and flexible. The hidden enemies, as we know, is the pressure nowadays. How do we downsize the PCNL size? And we have the suction revolution, and what about the 2 to 3 centimeter stones? I don't want to go into the detail, but since the century we have downsized all the PCNL tracts and ureteroscopy tracts nowadays. The reason is about the bleeding, that we have less bleeding and we have faster recovery due to the downsize. We have fewer complications and we can have wider indication, especially in pediatric patients or narrow ureters. So this is a law about the engineering point of view. If you want to downsize, then you have to sacrifice a vision, or you have to sacrifice the flow. So if you shrink the outer diameter, then you lose the optical resolution or the flow rate. So it has to be in some kind of balance. In 1980s we had the rigid, therefore we had the semi-rigid ureteroscopes. After the fiber optic flexibles, the digital flexibles, and the single-use nowadays. I would like to ask the audience, how many of you, your centers, reuse digital flexible ureteroscopes? Can you raise your hands? Reuse? And what about single use? So in my practice we used to have reuse, and nowadays we only have reuse. So if we, for the semi-rigid ureteroscopy, we know that if we have a small caliber, 4.5 or 6 French, we have a higher stone-free rates, fewer injuries, and shorter hospital stay. But Professor Traxler showed us that he is only using flexible and not semi-rigid at the moment. Maybe we'll, in the future, going to shift to flexible ureteroscopes, and we will not have any kind of semi-rigids. I don't know, we will see that. When we compare the single-use and reusable ones, there's no cross-contamination with the single-use, and the cost has decreased dramatically, therefore, and the availability is there. We have shifted to single-use ureteroscopes. We were in China 2 weeks ago, actually, and I wanted to use the engineering point of view. This is the 6.3 on the left screen that you use, and when we were at the EAU in London, we had seen the 6 French, actually. And I wondered how we can use lower track sizes. Do we need them or not? And as some companies, this is Sherry Lee that is answering us from Happiness Works from China, and they have the 6.3 that you can see here. So I think this is one of the most important slides that I have to show you. When we look at the 6.3, many people will say this is the limit. This is the most robust structure, and it has excellent optical performance. It's ample reflex space and high versatility. but the companies are going a little bit downsized to 6 French. This is a balanced trauma profile. It has good maneuverability and reliability, and there is an adequate space for the irrigation to come out. When we go to 5.1, this is extremely low mucosal trauma. It's less than a double J stent, 6 French diameter. It has excellent reflex about the pressure, but it has severe optical and structural constraints. And it's really high cost for complex, and it's complex in manufacturing. So this is a high-end product. We don't know if we need that, and it's not feasible for mass production at the moment. The 6 French seems to be the way to go, but it will depend on the company point of view about the costs. It's the most ideal mainstream size for adult retrograde internal surgery, which will be used for pediatrics too. So why do we use, when we go to the ureteral access sheets, we use them because of continuous outflow. They have multiple scope passages, they decrease the pressure, they have decreased the time of complex cases. And also, if we have higher diameter of ureteral access sheets, we have ureteral mucosal trauma, as we know. And the hidden enemy would be the pressure, and nowadays is on the hot topic. The normal pressure, as Professor Traxart mentioned on his live surgery, is really low. It's between 0 and 2 centimeter water. The pilovenous backflow starts from 13 centimeters of water, and the kidney injury starts 20 to 40 centimeters of flow. When we have a mismatch of ureteral access sheet and ureteroscope, you can see on the left side that there is 11 sheet left up, 11 sheet fans with 6.3 French ureteroscope. There is a 1.6 millimeter diameter for the irrigation to come out. Therefore, there's enough space, and probably you don't have high pressure, and you are on the safe zone. When you look on the 11 French ureteroscope with 11 French ureteral access sheet with 9.5 French, you only have an outer space for the irrigation to come out 0.5 millimeters. So this would mean that you don't have enough space and you will have high pressure. So with the high pressure, of course, you will have sepsis or high fever postoperatively, and we don't want to have any kind of backflow. With the PCNL, we have a lower internal pressure, as we know. Also, the heat is another enemy. In case we don't have high irrigation and high outflow, we can have damage to the kidney. So, on the PCNL spectrum, with a standard PCNL 24 to 30 French, we really have low pressures. But with the ultra mini PCNL and micro PCNL of 4.8 French, we did have higher pressures, and most of the urologists don't use it anymore. The evidence says that the storm-free rates are comparable across tract sizes. The mini PCNL had lower blood loss compared to the standard PCNL and has longer operative time. But there is no clear evidence in overall complications. Therefore, the urology community has shifted to mini PCNL. And with a micro PCNL, there's a paradox of the high pressure. So this is going to be a balance. We don't need so downsized tracts with complications about the patients. The suction revolution was indeed coming in the recent years, in a couple of years, with a fans sheet, flexible and navigable suction sheets, which had flexible tip, active suction, and dust evacuation. The problems were solved at once. The internal pressure could stay below 30 centimeters of water. The fragments could leave via the sheet, and no dust were everywhere. and the lower internal temperature and pressure was achieved. The real-world evidence showed us that there was a complete zero fragment in 57%. There were 97% no fragments of A and B, which was lesser than 2 millimeters. The 30-day intervention was 2.8, and the low-grade fever only in 3.8, and ureteric injury 2% only. The battleground went with 2 to 3 centimeters actually, where there was a definitive randomized controlled trial last year from Professor Zeng comparing mini PCNL with FANS flexible ureteroscopy. The stone-free rate were similar, only the operative time were longer, and the transfusion rate, hemoglobin drop, the 24-hour pain scores, the hospital stay, and subcapsular hematoma were in favor of flexible and navigable access sheet compared to mini PCNL. So, regarding the ureteral access sheet downsize, I asked also Justin from WellIT, and I think we're a little bit lack, and they have some engineering point of view about the downsize. This is the second important slide that I'll have to show you. To minimize the morbidity, we always need a lower tract size of the ureteral access sheets, so they reduce the pre-stenting and less mucosal trauma. There is a physiological preservation of the inflow and outflow when we use smaller scopes. But there is a barrier actually. When they tried about the 7.5 French, the outer diameter, they didn't have the effect that they would require. And when they have the 8.5, again, it was a little bit in a limit. So they concluded with a 9.5 French ureteral access sheet with outer diameter of 11.5. They could evacuate the fragments of 2.8 to 3 millimeters. There was a limitation of 8.5 where the forces were extensive and they nullify the irrigation advantage. So if you have 8.5, the irrigation and outflow advantage decreases dramatically. In order to maintain the vortex effect, it's probably the 9.5 inner diameter would fit better. So when we want to conclude, these are the guidelines. What do they suggest to us? But as endourologists, we are usually ahead of the guidelines and we try to push the limits and we publish and the guidelines follow the endourologists. I will say that nowadays, higher than 3 centimeters, and as Professor Traxler has mentioned, maybe higher limits would go for flexible ureteroscopy with a miniaturization. The miniaturization began with a flexible ureteroscopy, but nowadays is on the adult cases. I will say that the limitation is the time and the cost only. And what comes next? Would it be the 5.1? We don't know. Probably the 6 is going to be at the moment with the optics, flow, and the size. Narrower fans, 7.5 or 8.5. Nowadays it seems to be 9.5 for the vortex effect so that we can go for larger stones. And real-time pressure monitoring seems to change our practice in the future. We are going to have more and more with CE marks, FDA, maybe many ureteroscopes are going to be in the market with the internal pressure, and with the robotically systems we may have larger stones, longer operative times actually. The take-home message on my side would be that miniaturization is not automatically safer. We have to keep the balance of it, and the intrarenal pressure is a silent driver for the technology, actually. We need to have lesser complications. And fans seems to be the genuine innovation in our years. I would like to Qatar Ahmet, all of you, and thank my resident Ahmet for helping me preparing this presentation. Thank you once again.
Thank you, Jawad, for excellent talk. And actually, we have to keep the schedule. We will take one question from the audience, and meanwhile, one comment. So your statement is smaller is better. So on one hand, we have an easier access, the more patient comfort. On the other hand, the longer operation, the less irrigation flow, the less heat dissipation, which raises the other concerns about temperature and infective outcomes, complications. I mean, what is your opinion? I mean, what's the balance between those hands?
Yeah, so it's a really tough and difficult question. I think everybody has their own answer with their equipment and with their patients and with their expectations. My first choice would be to have a short operation to benefit the patients with low pressure and good vision. In order to achieve that, you will have to have lasers, good ureteroscopes, access sheets, low pressure. So it's a little bit more balanced. I would definitely ask you what would be your first priority. Would it be the patient outcomes, patient satisfactions, stone-free rate?
No, safety first. Safety first.
Safety first, definitely.
Thank you. Thank you very much, Jawad. Yeah. And I would like to introduce and invite Ellen Jung with her story on intrarenal pressure.
Thank you very much, Helena, from being here with us. You've dedicated a big part of your research life, many, many years on the research on intrarenal pressure. So we are very happy to have an intrarenal pressure expert actually with us today. Thank you.
Thank you very much for the nice presentation, and good morning everybody, and thank you for inviting me here to Uzbekistan. I'm very pleased to be here in Tashkent for the first time in my life. So today I need my slides. Yeah, they're ready. Today I'd like to take you inside the kidney. Not to talk about laser settings or stone clearance, but about something we rarely see, rarely measure, and maybe rarely discuss: intrarenal pressure. Because what looks technically perfect on the screen is not always physiologically safe inside the kidney. Ureteroscopy is generally considered a safe procedure, and most patients recover without any problems. However, we know that postoperative sepsis still occurs, sometimes unexpectedly. So the real question is not whether ureteroscopy is safe in general, but why some kidneys tolerate our procedures perfectly, while others respond with systemic inflammation or even sepsis. Let me start with a case. A female patient with a large infected renal stone. The RIS procedure lasted about 80 minutes. Visibility was excellent. Fragmentation was complete. Everything went exactly as planned. This is the kind of case we would all describe as uneventful. And then, 4 hours later, the patient developed septic shock. Nothing in the operative report suggested trouble. No perforation, no bleeding, no warning signs, and yet something clearly happened inside that kidney. To be clear, most patients do well, but a small minority develop serious complications, and those are the cases that we do remember. So what separates the majority from the minority? Why do some kidneys remain stable while others trigger systemic inflammation? In the operating room, we monitor many things: operating time, laser settings, and laser energy, fluoroscopy time. But there's one variable that we almost never monitor, and that's intrarenal pressure. We do not see it, we do not feel it, and in most cases, we do not measure it. So what actually happens inside the collecting system during ureteroscopy? Today, I'd like to focus on three things. First, what we currently know about intrarenal pressure and renal physiology. Second, what clinical evidence links pressure to complications. And third, what we can realistically do in daily practice to reduce pressure-related risk. The kidney is not built to tolerate pressure. The collecting system is designed for passive drainage of urine, not pressurized flow. Under physiological conditions, intrarenal pressure is very low, typically around 0 to 10 millimeter mercury. Once pressure rises to roughly 15 to 20 millimeter mercury, fluid can begin to move back from the collecting system and into the renal tissue. Importantly, this is happening within the range of reached in routine ureteroscopy. So what changes once we intervene? The ureteroscope occupies the ureter, irrigation runs continuously, and outflow may be restricted by instruments. In effect, we create a semi-closed hydraulic system. Under these conditions, intrarenal pressure rises very quickly. These peaks are usually invisible unless we measure them. Experimental imaging studies that we did earlier show that intrarenal backflow begins around 20 millimeter mercury. At these levels, contrast can cross papillary ducts and enter the renal parenchyma. These are not extreme pressures. They are easily reached, especially when irrigation is increased to maintain vision. So intrarenal backflow may occur even during procedures that appear completely controlled. And animal studies help us understand the biological consequences. In porcine models exposed to approximately 30 millimeter mercury, medullary lesions followed the calyceal anatomy. Histology showed tubular dilatation and interstitial changes. So intrarenal pressure is not just a hydraulic issue. The kidney responds biologically when exposure persists. And papillary morphology may also matter. Conical papillae appear more compact and may resist a higher pressure. In contrast, compound papillae and flat papillae and medullary sponge-like systems demonstrate more backflow under identical conditions. So microarchitecture influences how pressure is distributed within the kidney. At a system level, renal compliance also plays a role. Hydronephrosis alters the pressure-volume relationship of the collecting system. And fibrosis and chronic obstruction reduce elasticity. In these kidneys, even moderate irrigation may generate significantly higher pressure spikes. We also see considerable variability between kidneys. Under identical irrigation conditions, some systems remain stable, while others show repeated peaks and backflow. This suggests that a single universal safe pressure threshold is unlikely to apply to all patients. So in summary, ureteroscopy frequently exposes the kidney to pressure above its physiological range. Backflow begins at levels reached in practice, and pressure behavior depends on anatomy and compliance. But the question is, does this translate into clinical complications? And so far, we have mainly talked about physiology. Let me now move to clinical reality, because post-ureteroscopy sepsis occurs in roughly 1 to 5% of patients, and most cases are manageable, but severe infections still occur. So the question is whether intraoperative pressure contributes to this risk. Risk models constantly identify predictors such as infection stones, diabetes, prolonged stenting, and longer operative time. More recent analyses also include high irrigation pressure. Pressure probably does not replace traditional risk factors, but likely amplifies them. We have now reached a point where we can actually measure intrarenal pressure continuously during the ureteroscopic procedure, not just estimate it. So what have we learned so far? Take this study. Even under seemingly controlled conditions, we see frequent pressure peaks above 30 millimeter mercury, not only during active irrigation, but also during routine maneuvers. But the important point is this: it's not just the peaks, it's the accumulated exposure. Each spike is not just a number. It may represent a moment where fluid, bacteria, and endotoxins are driven beyond the collecting system. And patients with the highest number and magnitude of these spikes are the ones most likely to develop postoperative sepsis. So this is not about rare events. It's about what happens repeatedly throughout the procedure. Human cohort studies support this correlation. In this study from Cochran and co-workers, patients who develop urosepsis have significantly higher intrarenal pressures, around 82 millimeter mercury versus 39 in controls. Baseline pressures were similar, suggesting that the intraoperative exposure is key in this respect. Increased pressure may also contribute to postoperative pain. Pyelorenal backflow and pharyngeal stress are recognized mechanisms of tissue irritation. Some studies link pressure exposure to inflammatory markers and discomfort. So pressure may influence both the infection risk and the patient's immediate recovery after surgery. Taken together, intrarenal pressure is no longer theoretical. It can be measured, and higher pressure exposure is associated with complications. The relationship appears exposure dependent, although a universally safe threshold is still lacking. So what can we actually influence? In practice, it comes down to three things: inflow, outflow, and the patient. Inflow and outflow, that's technique. That's under our control. The third is the clinical setting. Because not all kidneys tolerate pressure in the same way. And that matters because the same procedure can result in very different pressure exposure. So if you want to reduce risk, we need to manage what we control and recognize when the margin is smaller. First, irrigation matters. Gravity is stable, but often insufficient. And that's where we compensate with the manual flushing. Hand pump gives immediate effect, but at the cost of dangerous pressure spikes. Pressure bags are more controlled, but only safe if outflow is adequate. And even automated systems don't solve the problem if drainage is limited, although some data shows lower operative time and fever rates when using them. The second lever is outflow. Urethral access sheaths reduce intrarenal pressure, and larger sheaths reduce it further. However, this does not consistently translate into lower infection rates, suggesting that other factors remain important. Moreover, larger sheaths often require pre-standing and may lead to more urethral damage. Suction-enabled systems represent the next step in pressure control. By applying controlled negative pressure, they actively evacuate fluid and fragments during lithotripsy. Experimental and clinical studies show lower intrarenal pressures and fewer pressure peaks compared with conventional systems, and early multicenter data also suggest a possible reduction in infectious complications. Maybe you think, should I really use suction and pressure monitoring in all procedures? It might be a costly affair. But here is what also matters. Not all kidneys carry the same infectious risk. Positive viewing culture, infected stones, prolonged stenting, diabetes, advanced age, and large stone burden all increased postoperative infection risk. In these patients, pressure mitigation becomes particularly important. Strategies may include gravity in irrigation, careful drainage, selective use of access sheaths or suction systems, and a low threshold for staging the procedure. So let's now return to the opening case. Technically, everything looked perfect. Vision was good, fragmentation was complete, and there was no obvious intraoperative complication. And yet, the patient deteriorated. The question is no longer what went wrong, but what we may have underestimated. In retrospect, nothing dramatic have occurred. There may have been no perforation and no visible injury, but repeated pressure peaks, transient backflow, and an unfavorable clinical setting may have interacted. Individually, each of these may seem insignificant, but together they may have been sufficient to cause harm. So, intrarenal pressure is visible to the surgeon, but it may represent the hidden physiological stress within an otherwise routine procedure. On Monday morning, most of us will perform ureteroscopy again. We will not change everything we do, but perhaps we'll be slightly more aware of pressure. We may use gravity rather than a pressurized irrigation. We may optimize drainage earlier or stage the procedure in a high-risk patient. Intrarenal pressure is not always visible, but it is measurable and increasingly clinically relevant. Thank you very much for your attention.
Very interesting presentation. Thank you. If you have some question, please.
Helen, thank you so much for your excellent presentation. I would like to ask you about the compliance of the pelvic cell system, actually. I recently had one more septic patient, and when I retrospectively reviewed the CTs, I have a feeling nowadays that when I look at the CTs and see some kind of irregularity, I cannot explain that in a standard manner, but I may predict in a subjective way that the case is a little bit non-compliant, fragile, pelvic cell system. Is there anything that you can suggest us about a CT or the patient so that we can be more aware about the ureteroscopy cases that we will do on Monday?
Thank you for that question. Very good question. And I must admit, I wish I could give you a good advice, but from the studies I showed in my presentation, we know that the papillae that looks like conical, they are more resilient to pressure. If they're very flat and if there are compound papillae, we know that intrarenal pressure and backflow happens more easily. But unfortunately, it's not easy to see on CT. At the moment, we are trying to do studies using MR instead to see if we can find some kind of image modality that can show us beforehand that this patient is fragile and susceptible to high intrarenal pressure. But at the moment, it's difficult.
Have any question? No. Thanks for you.
Thank you so much for the presentation.
Now,
Question?
now we will participate in very interesting debates. The head of the temperature is a real problem in endourology procedure. The Dr. Emre Senar, yes, and Dr. Ali Talashinsky said no. Please.
Can I start? Okay. Good morning, everyone. My name is Emre Şener. It's a big honor, it's a big privilege to be here, and I would like to thank the organizing committee, my dear friends Azim John and Lorian, and all the community and all of you for being here. Today, I will argue that the heat, the temperature is a real problem in endourological problems. Not simply because heat exists, and of course it does, but under certain circumstances, it can rise to unsafe levels, affect the tissue, and potentially cause clinical problems. Today, this is a debate, and I will be debating against my dear friend, Ali. So, temperature. So lasers have two types of effects on the tissue. The first one is the direct effect by directly burning the tissue, and the other one is the indirect effect by simply increasing the temperature of the surrounding environment. So when we talk about temperature, we should keep in mind that this is not just a physical side effect of lasers. The heat matters because tissues get not only warm, but they can get injured. And that injury, the temperature is not the only determinant of that injury, but also exposure time is quite important. There are some risk factors that can be modified, like power, irrigation, outflow, and the anatomy. And sometimes the thermal thresholds that we are using might be a little bit tolerant, meaning that we might be underestimating the risk. So the first important message is that this is not just a laboratory issue. The human clinical studies are showing that the heat can rise up very quickly. So Tang, in his study, they showed that without irrigation, they reached the threshold of 43 degrees in just 8 seconds with 1 joule 20 hertz. And with moderate irrigation, this temperature threshold is not reached. And also a similar message is coming from another different study by ASOI, and the authors showed that while using sheetless TFL, the temperatures reach 43 degrees in most of the cases, and especially when they increase the power, in more cases, that threshold is reached. So already at this point, the message is more or less clear. In humans, the heat can reach unsafe levels very quickly. And the risk is dose-dependent. Gupta, in his recent study, showed that, especially with fragmentation settings, the thresholds is not reached, the temperature stayed low. But with dusting settings, especially with pop dusting settings, in most of the cases, this thermal threshold was reached. So this is also important that not every form of lasering is causing an increase in temperature. It's not dangerous. So it depends on a high-powered, continuous laser activation, especially in confined spaces. So when we take a look at the bench and in vivo data, when irrigation falls, the heat can rise quite fast. With very limited flow, with no flow, Volin showed that all the tested settings exceeded the 43 degrees Celsius. In another study, Winship showed that unsafe temperatures could occur within just a couple of seconds. And in another study, Alduki showed that with 40 watts, the peak calyceal temperatures could reach up to around 85 Celsius degrees. And as you can see, the same message is coming back over and over again. Low flow plus high power is a dangerous combination. So at this point, we can say, okay, the temperatures are going up, but what is happening to the kidney tissue? And this is where kidney tissue studies are becoming important. So in this study, Peteniaris showed that maintaining around 45 Celsius degrees for 1 hour caused substantial renal histologic injury at the first week. Interestingly, endoscopy looked relatively good, but the histology showed substantial damage. So the endoscopic view, the endoscopic impression might be underestimating the injury. Marom and colleagues added another layer to this issue. They showed that the heat is not confined to the collecting system, to the irrigation fluid. In a porcine model where they measured the heat at different parts of the kidney, they showed that the renal medullary thermal dose was exceeded in most of the cases. So the heat does not stay in the collecting system, it spreads to the surrounding kidney tissue. And the ureter may be even more vulnerable. Bonzagni, in this in vivo porcine study, showed that with low irrigation and 20 watts, the thermal dose thresholds was exceeded. And even if they increase the irrigation to 15 milliliters per milligram, minute, with 30 watts, the threshold was also exceeded in most of the cases. And they showed that lower duty cycle and higher irrigation reduced the risk. So they are advising to take some pauses throughout the operation. And Albacierra's work also supported this concept, showing that aggressive or burst-style TFL strategies increased ureteral modal damage. So the ureter, the risk in ureter is real. The ureteric mucosa is open to direct thermal injury, and this risk can be modified by modifying the technique. The strongest biological proof is coming from this study. This study is combining temperature measurements, the cumulative thermal doses, gross pathology, and histology. And the authors show that with 20 watt TFL, it caused frequent histologic injury. And in the ureter, in all the cases, they had major injuries, and lower power settings were safer without losing efficiency. So this is important because it shows that when the heat is pushed, it becomes a real tissue injury. And does this matter clinically? Yes. Villani provide perhaps the most relevant clinical data. Here in this study, with manufacturer presets, they had strictures in 11% of their cases, but in individualized settings, lower settings, they had strictures in only 1% of the cases, without losing the efficiency profile of the lasering. So it shows us that aggressive presets increase harm without improving efficacy. And the discussion is now moving beyond temperature, beyond histologic injury. It's going into real human clinical consequences. So my conclusion is straightforward. Temperature is a real problem in the urology. We should be cautious with higher power, especially in the fragile organ, the ureter. We can modify irrigation, outflow, we can have pauses, which are critical to reduce the risks. And the issue is not whether heat exists. It exists for sure, but it is whether we respect its determinants. If we respect, we can reduce the risks. And if we do not respect, then these laboratory measurements first become histological injury, and at the end, they become relevant clinical consequences. So at the end, it's your turn, my friends. Thank you very much.
Thank you, Emre. Sounds quite affirmative. And let's hear the opposite from Ali. Please. Ali Teloshinsky has a very profound research on this kind of issues. Thank you.
Dear colleagues, first of all, I would like to sincerely thank the organizers of the conference for giving me my very first experience in debate format, and especially Professor. He is, for me, just embodiment of what a true urologist should be, actually. We are both from urology and urology working group, and I hope there is no conflict of interest. So the literature contains substantial number of experimental and animal studies investigating temperature dynamics in fluid environment and closed cavities. This had led many of us to conclude that temperature itself should be viewed as a separate problem, and also prompted to perform clinical attempts to investigate its direct effects in real practice. Today, we can identify the main drivers of temperature increase, like high laser power, low irrigation, and restricted working space. But if we look more carefully, we can group them into two broader categories: technical factors and anatomical factors, with their own moderators. For example, laser power is strongly associated with stone size and stone composition, whereas renal pelvic AP diameter is favorable for temperature curves. As these factors become more unfavorable, the procedure itself becomes more complex, and not only led directly to increased intrarenal temperature, but also via impaired irrigation efficiency in the case of complex anatomy. Why I emphasize this point? Because the same upstream factors are also responsible for different phenomena. For example, in our recent meta-analysis, stone size, operative time, hydronephrosis all influence the incidence of renal hematoma. And today, instead of concerning these events, increased temperature, increased pressure, incidence of hematoma, infection, and so on and so forth, as an isolated and as a problem, we should recognize that they are often under-correlated with each other and also arise from the same underlying causes. So temperature is not a problem, it's a consequence. So where is the problem? The problem is suboptimal preoperative planning and the absence of tools for example, measuring stones. That's why we can see significant differences and the heterogeneity between specialists across studies. The second real problem, the absence of the approach how we can classify renal cavity. And it's especially important because anatomy is non-modified risk factors for success and also for events like temperature increase. And in our review, you can see that we was trying to consolidate all evidence, and there is no unified tools even to classify location of renal pelvis. For example, here you can see that across 27 randomized studies, only 8 of them included anatomical comparison between groups. So the next problem is the level of evidence we use when we speak about the temperature as a problem. Most of them came from animal and experimental works, and we know that these results cannot be fully or partially allocated to human cases. Next problem is, okay, if we are going to measure temperature, we do not have even the protocol for this. Which type of thermocouples we should use, how many, and how to place them. Brilliant phrases from this review you can see here. All used thermocouples across studies was inconsistent. And also temperature measured using thermocouples placed near the laser probe has been the surrogate. It's not direct measurement, it's surrogate. So if we are following evidence-based medicine and respect the necessity of personalized approach in our clinical practice, in next future studies, instead of considering temperature like a problem, pressure like a problem, we should try to find answers for next questions. We ourselves acknowledge that an animal anatomy is far from human, and experimental studies do not account for physiology at all. So why do we still say that temperature is a problem? If we are comparing two groups of patients with different laser settings, are we absolutely sure that the observed differences in temperature are not due to differences in anatomy? We know that laser settings depends on the stone characteristics, but do we have widely accepted methods for measuring size and density with minimal heterogeneity? Are we sure that in solving the problem of rising temperature, we will not worsen other outcomes? If we do end up measuring temperature, do we have a highly reproducible protocol that takes absolutely all factors into account? No answers yet. So, in my opinion, temperature is not a problem. It's a consequence of real problems. And temperature is one apple, but endourology is the whole tree. Thank you.
Thank you very much, Ali. I will switch to Russian because I want to address the audience. Любые дебаты, они предполагают голосование, выбор. И вот интересно, как считает аудитория, чьи аргументы были более обоснованными? Поднимите, пожалуйста, руки те, кто за то, чтобы температура измерялась во время операции, те за тех, что температура – это важный параметр во время уретероскопии. Поднимите, пожалуйста, руки. Теперь, кто считает, что температура не столь важна и ее роль переоценена или недоизучена? Как будто бы it seems like Emre at this time point has won the debate. So congratulations. Thank you.
Good. So hope you enjoyed the debate. Unfortunately, we are very late with time with this first session. So sorry to disappoint you. There's no coffee break for the moment. We will continue with the next round. And I would like to invite Emre to come back to us since you won the debate. You earn your place here. Yeah, well, this chair is your reward now. And also, Vigan and Murad, can you please join us and host the next session, which will start with, we have a small change of program. We'll start with Azim John presenting on radiation in endourology. Yes.
Dear colleagues, very nice to meet you. So we present the next speaker. I think he doesn't need any presentation. So Azim John Tursunkulov will talk with us and discuss and open the topics of ALARA principles. Please go ahead.
Thank you for announcing this presentation from the EAU Congress. Let me talk on Russian, okay, because of mostly our audience is Russian, and this is a very sensitive topic. Мы сегодня будем говорить про облучение во время операции. И этот доклад я сделал в предыдущих конгрессах, так как это очень важный аспект нашей практики, и многие, к сожалению, мы на это не обращаем внимания. Могу ли я попросить вас, что сколько из нас использует рентген во время операции? Поднимаем руки. А теперь, сколько из нас мерим, сколько мы используем рентген? Кто смотрит на дозу рентгена во время операции? Время рентгена кто смотрит, кто соблюдает? Ну, практически никто не смотрит. Поэтому мы сегодня будем говорить про принципы ALARA. Значит, что такое ALARA? Это как можно меньшую дозировку использовать во время операции. По возможности, по мере возможности, мы должны максимально минимизировать использование рентген-радиации. Как мы видим, что рентген имеет разные эффекты, значит, это ожога, это руки нашего коллеги, травматолога, к сожалению, который долгие годы работал под рентгеном и получил такой эффект. И также мы имеем генетические эффекты, которые могут возобновить предрасполагающих факторов, например, онкология, у кого-то есть генетическая предрасположенность, и этот врач работает под рентгеном, бесконтрольно использует, это он может спровоцировать раковые заболевания. Значит, мы, хирурги, больше получаем непосредственный эффект путем непрямого облучения, так как прямое облучение попадает на пациента, но от тела пациента, от операционного стола на тело хирурга, на руки хирурга мы получаем большую дозировку облучения. Значит, по статистике, пациенты, страдающие мочекаменной болезнью, они получают самую большую рентген-нагрузку, так как с момента обращения к врачу они начинают диагностику, рентген-диагностику, компьютерную томографию, потом они находятся в операционной, как мы уже указали, под рентген, Потом также после операции на follow-up пациент приезжает, мы часто их просто направляем на компьютерную томографию. Как мы видим, что хирург получает всего лишь 0,1% облучения от того, что пациент получает во время операции. Значит, если смотреть по позициям, то при перкутанной хирургии пациент и хирург, кто оперируется в положении на животе, получает самую большую нагрузку по сравнению с супайном. На этой публикации мы видим, что с развитием понятия алара мы намного снижаем уровень дозировки облучения рентгена врачам. Как мы видим с этой публикации, что в 2000-х годах в среднем использовались 28 минут. Среднее время использования рентгена было 28 минут, и за это время хирург получал от 21 до 40 микрозиверт облучения. Но уже к 20-м годам, как мы видим, что время облучения сократилось до 4 минут, и, естественно, доза облучения до 2 микрозиверт. Как мы видим, что 10-кратно снижается облучение чисто из-за того, что мы знаем кое-какие понятия, как использовать рентген правильно во время операции. Значит, какие принципы алара? Значит, радиацию мы должны использовать только когда использование рентгена превышает потенциального риска облучения. Также мы должны оптимизировать каждый шаг использования рентгена. Также мы должны поставить лимиты для использования. Как мы это делаем? Значит, какие факторы, которые увеличивают объем дозировки, это значит размер камня, размер тубуса, также камня с низкой плотностью, использование множества трактов, также использование рентгена, когда во время формирования доступа. И также часто мы делаем, что мы вообще не проверяем, какую вообще мощность рентгена мы используем. Как мы видим, что здесь на этой публикации, что множество исследований были проведены, и один из них, сможет ли заменить перкутанная хирургия под ультразвуковым доступом, сможет ли заменить, полностью убрать рентген из нашей практики. К сожалению, к такому понятию мы не сможем прийти, пока достоверных данных нету, чтобы полностью переходить на X-ray-free хирургию. Значит, что мы должны сделать, чтобы снизить дозировку? Это использование чек-листов. Это кое-какие параметры, которые мы должны соблюдать, проверить, значит, дозировку, установка рентгена, дистанция рентгена, где находится трубка рентгена. И всего лишь использование вот этих чек-листов уже на 25% снижает дозировку облучения. Какие, значит, мы должны соблюдать принципы? Это в первую очередь защита пациента, потом уже защита врача и его команды. Значит, использование точного рентгена. Перед операцией обязательно проверить уровень дозировки рентгена и снизить до максимального уровня. Также использование флюороскопии, режима флюороскопии, точной флюороскопии. Также использование коллимации. Так как коллимация, это мы используем большой фрейм, да, рентген нам показывает тело пациента, еще половину стола тоже показывает. Мы должны вот это максимально сократить и максимально использовать именно точную, где нам надо, вот эта локация, это будет очень много снижать дозировку рентгена. Конечно, для этого требуется и опыт хирурга. Также использование рентгенозащитных средств. Как мы видим, что один из ключевых факторов снижения дозировки рентгенооблучения – это опыт хирурга. Значит, Inverse Square Law – это закон, когда мы на шаг отступаем от рентгена, мы уже автоматически в 2 раза снижаем дозировку облучения рентгена. Как вы здесь видите, что один шаг уже в 2 раза снижает. Если мы еще дальше ставим, мы можем уже 3 раза, 4 раза уменьшить дозировку рентгена. Это же, опять же, требует оптимизации работы команды в целом, основного хирурга, где как находиться и над этим работать, чтобы соблюдать кое-какую дистанцию. Как мы видим с этой публикации, что дистанция, насколько важную роль играет во время уретероскопии и во время перкутанной хирургии. Как мы видим, что нахождение хирурга в дистанции 60 сантиметров по сравнению с 35 снижает дозировку облучения от 2 до почти 0,8 микрозиверт дозировку. Очередной трюк – это всегда трубка рентгена должна находиться под столом. У нас некоторые коллеги, они используют, что трубку иногда находится наверх. Всегда трубка рентгена должна находиться внизу под столом. Это намного снижает дозировку и пациента, и также основного хирурга, и также команды. Значит, как мы видим здесь, что кто работает с трубкой наверху, они получают 10-кратно большую дозировку рентгена во время хирургии. Значит, какие трюки? Рентген мы должны установить так, что трубка должна максимально находиться внизу, и флюороскопический час должен находиться максимально ближе к пациенту. Ну, естественно, если установка трактов позволит на это. Как мы выше упомянули, это флюороскопия, во время использования рентгена, что мы должны использовать точную флюороскопию и сохранить предыдущее изображение, чтобы ориентироваться больше на это. Это опять же требует опыта, и как многие из нас уже учителей, мы должны этим обучать уже наших молодых коллег, так как многие это не знают, и они получают очень огромную, очень вредную дозировку рентгена. И также используют коллимацию, максимально сокращать зону попадания. Если мы будем использовать флюороскопию, точную флюороскопию, коллимацию, как мы видим, что мы уже с вами получим очень большой эффект. Как вы уже видите, что от 3 микрозивит мы можем снижать дозировку рентгена до 1 или до половины микрозивит. Это очень болезненная тема, что, к сожалению, многие из нас мы не используем рентгензащитные средства. Например, кто использует защитные средства для щитовидки? Как мы видим из этой публикации, что если мы используем весь спектр рентгензащитных средств, то мы сокращаем излучение до 98%. Если кто использует рентгензащитные средства, им можно провести до 2000 операций в год. А если кто не использует рентгензащитные средства, они не должны превышать количество операций от 45. Это официальная публикация. И также интересная статистика, что 99% нас используют фартук. Как мы видим, что перчатки мы практически не используем, рентгензащитные перчатки. Хотя именно они спасают наши руки от прямого излучения. Что нам показывает таблица, что самый опытный хирург – это не показатель, кто уместно использует рентген. Кто знает принципы Аллара, он и использует и он и получает минимальную дозу. Как вы видите, что самое максимальное количество, кто провел операцию, он получает самую большую дозировку. А кто проводит самое большое количество, при этом используя принцип Аллара, он получает самую минимальную дозу. Значит, какие мы должны соблюдать правила, чтобы сокращать? Значит, во время перкутанной хирургии максимально использовать ультразвуковой аппарат для доступа. Также во время уретероскопии при установке проводников, при ревизии мочеточника мы должны использовать максимально визуальный метод, чтобы, конечно, для этого требуется опыт хирурга, но мы можем уретероскопом достичь таких же результатов, как и под рентгеном. Значит, какие показатели для использования принципов Аллара? Это чтобы достичь этого эффекта, до 86% сократить получение излучения. Если мы будем использовать Аллара, то мы это можем достичь, как вы видите с этой таблицы. В заключение хочу сказать, что мы всегда заботимся о здоровье пациентов, мы множество пациентов оперируем, и мы о себе не помним. Поэтому я всего лишь хочу, чтобы мы помнили о себе, чтобы в первую очередь, чтобы мы защищали себя. Спасибо огромное.
Thank you, Azimjon. If we have some, brief questions from the audience, I see the raising hands. Please get to the microphone and ask your question. And before you're reaching the microphone, you disrupted again, Azimjon. So I don't know which language I should speak. I would say one phrase in Russia, from Russian speaking, because they would understand this better. So what I wanted to say is, все прекрасно помнят, что делают вот наши советские люди, когда у них кричит тревожный, в машине кричит тревожный, тревога, аларм о том, что не пристегнут ремень безопасности. У них есть специальная пустая такой плаг, и они его вставляют просто, чтобы сидеть и без ремня, и без, соответственно, ремня безопасности, и без вот этого удручающего звука. Я просто хочу сказать, что это очень важная тема, о чем сейчас говорит Азимжон, и нам нужно поменять что-то в нашей голове, потому что в нашей клинике, к сожалению, до сих пор урологи до сих пор никак не реагируют на это, кроме как просто нажимают согласен, согласен, согласен. Для них это пока что пустой звук. Please go ahead with your question.
Здравствуйте, уважаемые коллеги. Спасибо за ваш очень интересный, важный, полезный доклад. У меня такой вопрос. На принципе Аллары это protection фартуки, свинцовые. А как мы знаем, ношение свинцовых халатов 0,5 мм при протяжной операции, множественных операций влечет за собой напряжение, то есть усталость хирурга, хронические боли в плече, в шее, да? А как вы думаете, что важно для хирурга? Зарабатывать себе хронические боли в шее, в плече? Или важно использовать в 2 раза меньше размер фартука 0,25, чтобы не вызвать такие осложнения?
Икромбака, спасибо за вопрос. Очень интересный вопрос, кстати, но, не знаю, может быть, коллег знает. Я, честно говоря, не читал таких публикаций о том, что там какие побочные явления от фартука, например, для позвоночника. Но так как мы здесь довольно большую аудиторию имеем, мы можем спросить, что у сколько наших коллег имеются проблемы там с позвоночником, с шейным отделом. Там. У меня иногда бывает боли.
Спасибо большое. Я сейчас просто, у нас есть человек, у которого никогда не болит шея, судя по его размеру, это Нариман Казиханович, но я думаю, что судя по его комплекции, его не берет и радиация. Поэтому я думаю, что нам нужно послушать его комментарий.
На самом деле я полностью согласен с коллегой, потому что люди, которые занимаются камнями с утра и до вечера и носят эти свинцовые фартуки, не может не быть проблем со спиной, с шеей, так или иначе. И у меня в жизни тоже были такие моменты. Я для себя нашел решение, это фартуки, бессвинцовые фартуки. И есть и корейские компании, которые весят там буквально 200-300 грамм, и можно носить их целый день. И мы проверяли их на рентген-безопасность, они в принципе соответствуют 0,3-0,5 свинцовому эквиваленту, как вариант решения.
Нариман Казиханович, пожалуйста, не уходите. И буквально еще один комментарий. Я знаю, у Наримана Казихановича была такая публикация интересная, как еще этот вопрос можно решить при помощи коллимации и снижения непосредственно самой лучевой нагрузки, интраоперационно понижая и регулируя, управляя параметрами, собственно, нашей цедуги.
Здесь все достаточно просто. Действительно, мы сужаем поле, мы не делаем зумов, ни в коем случае никаких свинцовых перчаток, потому что сейчас все эти автоматические усилители, они просто будут усиливать лучевую нагрузку. Обязательно frames per second, то есть ни в коем случае не оставлять, то есть можно делать 5-6 фреймов в минуту, и тогда у вас значимо, практически там в 5-6 раз падает облучение во время операции. Естественно, все должны быть одеты, и все знают эти пресловутые 3-6 метра, за которыми, в принципе, радиация уже носит такой фоновый характер. Поэтому здесь все, как я Азимжон говорил, абсолютно правда, согласен полностью.
So thank you for your comments, and I think we no further question in the audience. So thank you, Azimjon, one more time.
I have one comment about this. Or another solution is you can just switch back to prostates. and not deal with radiation at all. This is a solution.
Thank you. So we have another comment from the Master of Endourology.
Well, I
yeah, Peter
just want
Alkin,
to tell
please.
you, I started the whole business 50 years ago, and at that time we weren't so aware of the radiation damage. And slowly we did collimation and shorter time of fluoroscopy. But at the end, I never used a lead shield for the head area. And 10 years ago, I had cancer of a salivary gland, and a few years ago, I had a tumor of the parotid. So I warn you to go on and do a lot of radiation to yourself, because at the end, you will suffer from the effects.
Thank you.
Use protection.
Thank you for your comment. I think yes, it's always better to be on the safe side. So we go on, and I think
We
please
will continue with the next presentation, which will be online, and the presentation will be given by Vineet Guhar from Singapore. The topic is clearing the stones, how suction is transforming endourology. So can we connect to Vineet, please?
Hi, good morning.
Morning, Vineet.
Are we able?
Yes,
Are we able to hear me?
We can hear you, but we
All right, great.
You're with us.
See.
I think that there's been some issue with me trying to upload my presentation, so I've sent it to them, and they're going to play it for me. And whilst they do that, let me take the opportunity to thank Azim John and the organizers of the meeting. Profound apologies for not being over there. And I can hear that, and I can see that there's been an amazing set of discussions. A very warm regards to Professor Peter Alkin. Good memories from last time come running back to me, and hopefully we can share them again soon. If somebody can just play my presentation, please.
Can you repeat what you said last, please, Vineet?
I'm just requesting somebody to please play my presentation.
Can we play Vineet's video, please?
I was trying to present it live, but for some reason I'm not able to share it. So just hoping that somebody can play it for me.
So we are asking the technical staff to run the presentation of Vineet Guhar. And is there any technical possibility to share your screen? Oh, yeah. So we see it's perfectly seen. Vineet,
okay.
Go ahead.
Okay. So I've been tasked with presenting on how suction is transforming endourology. Next slide, please. I'm so sorry. I'll have to verbally tell you to do it for me. But I'm going to restrict it to ureteroscopy because I think endourology is too advanced a field. Next slide, please. And these are, of course, my disclosures. The next slide, please. So as you can see, we are technically living in the world where endourology is transforming, has already, I would say, transformed all these factors which were considered at one point of time as a difficult choice in RIRS, which was vision, temperature, pressure. And today where we are, when we introduced fans and we introduced discs about 3 years ago, we were all wondering whether these are technologies that will take up, which will be acceptable as norms, and whether the industry will be allowing us to study it more. And we did mention at that time that unless we extensively evaluate it, we probably will not get the answers on how to use them in the best way. We've moved far from there. Next slide, please. Could I have the next slide? Okay. So we now in 2024 had finally convinced even bigger bodies like the EAU and to some extent even with the American Urology Association that suction has to be an integral part of endourology. And this was still skepticism whether suction should be done in all patients. Should it be used in all cases? Can it be used in all patients? And can it be used in all cases? Which is the better way to do, whether it's ban this or there are newer technologies that need to evolve and move on from here. And this is hardly a year and a half ago. Next slide, please. What changed with suction, and to me, that is where the definition of the revolution comes, is that we started to passively clear stones, actively move the sheet or passively absorb all the dust. We didn't need baskets and we didn't need to move in and out to remove the stones. It was an achievable goal. At the same time, it was a dynamic control over the intrarenal pressure, temperature, and visibility. Why dynamic? You can actively, real time see it. We now have the technology which can measure it. We saw the talk from Ali and we also saw the talk from Emre, which said it's mandatory to have these components under control. And I think the revolution is because suction is the final piece of the puzzle in stone management. There's never a finality for anything, but final, when I say, it seems to be the one which we can teach most people to use, and that is definitely changing the game. Next slide, please. Can we go to the next slide? Thank you. So I expect the audience to bear with me for some of the technical glitches that will happen. But once we started to remove the stones actively, we then wanted to better make our surgery proficient in terms of operative time, workflow, the cognitive burden which comes on with the more difficult stones, and of course, ergonomics. And this sometimes we suddenly realized that maybe we've actually made surgery a little more complicated because now we had too many parameters to consider because we wanted surgery to be safe, we wanted to have zero residual fragments, we wanted every case to behave in exactly the same way, whether it was done by a consultant or whether it's done by a resident. And sometimes we expect too much. And then, of course, there's skepticism which says suction probably is not all that good because it's making surgery more complicated. But if you find dissected, next slide, please. One by one, the pieces of the puzzle are fitting in together. If you look at operative time, finally, we have the answer to tell you if you have the experience, if you use the technology well, if you learn how to use the correct technology. Let's say, for example, with fans, you can do RIRS more than 90 minutes. If you don't know how to do a surgery, you can't even do a PCNL well, or even for that matter, any other surgery. So, but once you do, 90 minutes may not be the reason for you to stop surgery. We had that confidence to proceed and use suction in a much better way because ultimately your aim and my aim is to make the patient completely stone free so that he doesn't come back for a second intervention. We also want to make sure that when we increase the operative time, we don't influence temperature and pressure to a point where they become catastrophic. Instead, we want to control them so that the surgery is absolutely safe. Next slide, please. This opened up a new area. The revolution that happens when we gain evidence is now you can do bilateral stones in a much safer way. So when you're sitting down or you're standing and doing the surgery, you spend longer time and you can be safe. And don't worry, you will be able to do an equally good surgery on both sides. But if you do this at the end of the day, when you're tired, you've done 10 surgeries, for sure you and me are going to be tired. So you respect the limitations of your own ability to make suction revolutionary for your patient. Start the surgery when you're fresh, look at the evidence which says you can do it, and use the right instruments, and 100% there's no reason why you and me can't have the same results. Next slide, please. Next slide, please. Yeah. So here, for example, is when you really push the limits. You'll find patients like these who are complicated. These are daily wage earners who really need to get back to work. They have kyphoscoliosis, bilateral stones. They've been coming in and out of the hospital many times. Now we're able to spend 130 minutes. We're able to spend about 90 to 100 minutes with the fans instrument inside. With evidence, we are actually able to show you that it doesn't matter, you can do the surgery well. Patients have been followed up even up to 1 year. We have a new paper which comes up even after 1 year, not only 3 months, even up to 1 year, that they don't develop complications. Why? Because we understand now that suction controls the stone fragment removal, it controls the pressure, it controls the temperature. The only question is, can you do the surgery well? And that comes with experience and training. Next slide, please. Next slide, please. This would be always the question that was asked. Can it be comparable to the standard of surgery, which is PCNL? Because for the last 20 years, until suction and RIRS came, PCNL was the norm. There's always this question about 2 to 3 centimeters. I only put this slide up because this slide explains everything. The 2 to 3 centimeter concept is gone. We're looking at stone volume. We're looking at PCNL versus RIRS, where we want to understand the stone burdens that these surgeries can manage. Next slide, please. If you look at it it's hardly 29 minutes more than a suction PCNL that you can get the same outcomes because it's a non-inferiority study. Whether it's a lower pole, whether it's a stone up to 3 centimeters, whether the patient is in a complex anatomy or a simple anatomy, you can actually get the same outcomes. So if I do have this problem, both the options available, can this even apply to the next set of complicated cases, which is the infected stone? Because now we are moving the revolution to see how best we can use suction. Next slide, please. We can, because the same reasons that we stated before. We could control the pressures, we could use suction properly. If you do that, treat the patient adequately, respect the rules of infected stones, there is no reason why you can't do them in infected stones. Not acutely infected stones with pyonephrosis, but those which are treated adequately have been drained either with a PCN or a stent. The challenge is when you put up a paper like this, it is bound to receive criticism because people tell you, if you have pus, should you do the surgery? No, it's not changing the ethos of practice. It is just changing the way you get the outcomes, because we could not do this with RIRS before. But now we can confidently do it with RIRS, and you do have the ability to tell your patient, there are choices. In your hands, you use which is the best choice available for you. Suction PCNL versus suction with fans. You have two choices. Use whichever you think is the best option, which you can use. Next slide, please. Hence, we have these parameters which are absolutely important to consider. And this is where I think the evolution of suction is making another revolution, which is controlling all these. Next slide, please. Next, please. Just keep, yeah. I would come down to the fact that because of that, the whole sheath is evolving. We are moving from a simple sheath, not using an access sheath, to using an access sheath, using an access sheath to fans access sheath, to now using it with the IRP monitoring or even an intrarenal temperature monitoring sheath. At this point of time, it's an intrarenal pressure monitoring, but there is an intrarenal temperature monitoring sheath coming as well. Next slide, please. And the evidence is coming out day and day because there are so many of these instruments available. At this point of time, for me, it's most easy to use suction with an intrarenal pressure monitoring sheath. Next slide, please. If I have to use for my patient, I would choose the last option, that why would not I use an IRP monitoring fans, because I'm used to using fans. I just have to add another parameter and just monitor the IRP. Next slide, please. Because all of us, we need to evacuate the fragment, which we're already doing with fans. We know that the IRP is controlled, but if we can see it simultaneously, we don't have to do much about it because these systems are so intelligent, then why not use that system? Next slide, please. To prove that evolution and revolution or advancements don't happen randomly, we know Nariman. Nariman is a good friend. So I told him, he said, why should I shift from gravity irrigation? I said, okay, let's do an experiment. So we did it, and he himself came out and we presented this at the EAU. If you use mechanized irrigation, when you have a flow rate of 100 ml per minute continuously, you are bound to get much better influence over the way you do the surgery. And automated irrigation systems have now become mandatory. The reason I say that is, if you don't change your practice, obviously you need to invest in technology, but technology gets cheaper with more users. But as evidence comes out, it tells you that there are certain rules and regulations that you follow, and the surgery becomes absolutely safe. we are moving towards making suction and endourology very idiot-proof. When I say idiot-proof, it should be so automated that you sit down and everything should be taken care of. Next slide, please. This is not just evidence in the lab, it's also clinically showing. It's now, if you use these systems, there are studies to tell you that your operative time comes down, temperature is taken care of, we don't hit that 43 degrees anywhere by using adequate irrigation. So there's no thermal injury, no direct thermal injury or lateral thermal injury. So I would combine everything, and this is where I feel the next revolution of suction is taking place. Next slide, please. We look at it from further evidence which is coming in. If you have high power lasers, it makes no sense to be using them as low power lasers today. And Wigan has done a very nice study which clearly tells you, you increase the wattage, you manage the irrigation and the fluid properties and the suction properties. There is no reason that your laser activation cannot be increased beyond the 20 watt. There is also good enough proof to tell you that when you increase irrigation, manage the suction, that you can actually do lasing more effectively. The pedal time goes up by 2 minutes. And that's why the whole laser experience gets better. So the next change that has happened with suction is no more about fragment removal. It's about lasing efficacy, laser lithotripsy, and also about how well you manage pressure and temperature. Next, please. If you take both these, we took them to the lab. There were lovely evidence from both these gentlemen, and I took them to the lab, and I can clearly tell you, next slide, please. A summary of all that we have learned with suction. No, go back. Yeah. If you use continuous irrigation at least 60 ml per minute, you can actually continuously fire the laser for 1 to 2 minutes. You will not have a problem with the temperature or pressure when adequate suction irrigation is balanced. And you are likely to be using more and more of fans if you respect the ratio of sheet and the scope diameter, which is 3 French. So it's quite simple. It's not very complicated once you understand this. Next slide, please. And that's why companies are listening to this evidence, and now they're telling us, yes, we will develop these systems. There are 4 to 6 of them coming in the market, and these are what we call as automated irrigation systems, because next slide, please. I would like to use this in every case. In a low hole stone, in a pediatric case, smaller scopes, smaller sheets. I want to miniaturize the surgery. For that, next slide, please. I really need to be using it in 2-month-old patients or even a 100-year-old patient. Whether I'm going to use it with this or whether I'm going to use it with fans, I need to combine automated irrigation, which can manage temperature and pressure, and tailor the approach to the patient. And that's why industry is developing instrumentation faster and faster. Next slide, please. Just to give you a teaser, the irrigation which comes through a scope, imagine if you can put the irrigation through a sheet. We give you the whole scope channel free for you to use any laser fiber. You want an extra source of irrigation or you want to put a basket inside it, but you still want the irrigation to be maintained. We requested the company, can we do it? And this is a new sheet which is coming out probably by the time the ICE meeting comes up. Next slide, please. What it does, it combines automatic irrigation, pressure and temperature control, irrigation through the sheet. Your scope is totally free. When somebody looks at this, the company comes to me and says, can I use a 4 French scope through a sheet like this? Because now I don't really have to have a working channel for water. And they can give you a small working channel for a 150 micron laser. And this is how revolution in endourology and technology is happening. Next slide, please. We take the principles of what we've learned. We know there's CVAC and instruments like that. And we said, can we make a system which can automatically regulate temperature, pressure, irrigation? You just press play and everything is taken care of. Can I even automate it so much that I don't need to move in and out of the system with my hand like I do in fans? Can everything come out through that? Sure. There's a company which has come out with a system which we have evaluated. What the first 70 to 80 patients that we did, it works wonderfully. There are restrictions. It's slightly bigger. It's a 12 French. So whether you use that or you prefer a smaller one, that's what we need to learn. Next slide. The definition of success is completely changed with the revolution. And we won't spend too much time, but you have to aim for a 0 fragment status each time. it's the only way that your patient won't come back for intervention. What it has done is taken out the definition of clinically insignificant residual fragments or clinically significant residual fragments. People are talking about, are you stone-free or not stone-free? There's no more of those complicated definitions. Next slide, please. For me, a patient comes into my hospital, he should go back home in 24 hours with a CT scan documented that shows you are 100% stone-free. And to me, that is the epitome of how suction should proceed forward. Any suction technology should be able to replicate that. Next slide, please. And I think suction is a necessity in 2026. It's no more whether suction is important or not important. Whether you use through a scope or through a sheath or through some other technology, that's up to you. There is going to be a learning curve every time you change technology A to technology B. So please keep that in mind. Next slide, please. Next. Can you play this video? I just wanted to hear two very prominent surgeons. And one is interviewing the other. And Karen asked Naeem, and they were two skeptics who were really wondering whether suction is important for all cases. And I don't know if you heard it, but he clearly says, I will not do any surgery if there is no suction involved. And to me, that's the best answer that even I can give you, because I don't think even I can do that without using suction today. Next slide, please. So yeah, if you want a summary of everything that's given, this evidence will summarize it and then open up new agendas. Next slide, please. But we also caution that as technology improves, we really need to be very careful of how to use it. And if you are careless, then they say a tool in a fool's hand is still never going to be really acceptable. A fool will not be able to do a good surgery. We are not fools. We are intelligent people. We are doctors. We want to understand how to do best for our patients. We've got to learn, but we have to adapt and we have to change. And if we don't, then the industry is going to push us to change. And training is really, really important. So I feel we should focus a little more on training and evidence-based management of suction patients. Next slide, please. Yeah, I would just say that we've come a long way. What's important today to understand is that suction is revolutionizing both PCNL and flexible uteroscopy. We just need to be closing in that game where which is the maximum stone limit we can operate each. We are miniaturizing suction in PCNL, and we're maximizing the outcomes of miniaturized RIRS. And I think we're just at the crossroads where probably in a year or two, both these modalities will be equally effective in any case. Thank you very much.
Applauses. Thank you. Thank you, Vineet, for a wonderful lecture. So I think we should take some questions.
Have time.
Yes, we have time. And first of all, if I may, sorry, I just very curious. So this is a very provocative question. Vineet, do you hear us?
Yes,
Vineet?
I can.
Yes, Vineet. So we hear you too. So the next presentation, I guess, would be my presentation, and I would be presenting a pre-recorded case on offense surgery. So, and I was just wondering if we are ready to reset our standards concerning regarding the stone-free rate. Is there a limit of zero fragments is the standard already, or we should, we still have a way to go for that? Thank you.
No, zero residual fragment or 100% stone-free should be the standard of care. Are we adopting that standard of care? We are trying to adopt it, but a lot of people don't understand that a zero residual fragment is only proven with the CT scan. It only happens if you spend enough time to make sure that you actively remove all the dust and the debris and the fragments inside. And if you want to make this as a guideline statement, then we definitely need to adopt this as our day-to-day practice. The problem is, you and me will probably adopt this because we believe that, evidence is good, it points towards this. But can we make every surgeon do the same? That is where it takes time. But 100% sure that 100% stone-free rate is good for the patient. There's enough evidence from all technologies in suction, be it PCNL or RARS, that patients have less interventions, less need for post-operative stenting, pain, infections, and even the surgical experience quality of life is much better. So I don't see why we shouldn't aim for zero residual fragments when the evidence clearly points so.
So we have a question from the floor, from Arman Saturian.
Yes, please.
Hi, Vinit. Thank you very much for the wonderful presentation. It's nice to see you here, although not personally, but still virtually to have you here. My question is, you mentioned 50-60 ml per minute, right? So should it be the 50-60 ml which is indicated on the systems, or that is the 50-60 ml from the ureteroscope to have this amount of fluid coming out of the ureteroscope?
Great question, Arman. So when we set on the system any amount, whether it's 100 ml or 200 ml, right? For example, when you started to use gravity, you said, oh, my gravity, if I raise it to a certain height, it's going to 60 ml. Now imagine that has to come through a scope, it has to come through a tube, it has to come through the channel of the working channel of the scope. There is a dead space that it has to conquer. On top of it, we put an instrument inside, which is like a guide wire, or we put in a laser fiber. That further reduces the flow rate. What did you do when that happened? You increased the height of the irrigation, or you put a pressure cuff to that irrigation. You managed to increase the irrigation a bit more, but at any point, you were not able to exactly know how much of fluid is coming to the kidney. You assumed that it was enough, you assumed it is 60 ml, but there was no way to measure it. So then we came out with the systems which said, put them on the system 100 ml per minute, or X amount of millimeters. Yes, they generated that pressure and they generated the fluid at the starting point, but it still did not translate to that inside the system. And this was where I had a problem with the endoflow and the endomat, which is probably why we needed the trachea pump as well. But that was the best available option, which had made some advancement for RIRS in the 2000s and 2020s. But it was not enough. It did not take care of the temperature and pressure, and hence we were restricting ourselves because we could not increase our lasing efficiency. We did not know that we can do suction without causing bacteremia and sepsis until we had automated irrigation and pressure systems. The problem was these companies came in, they made great systems, I don't deny it, but they did not teach us how to use it. There was no evidence. So finally, we had to create the evidence to tell them, if you are using technology A, which is fans, or technology B, discs, can I use it with certain parameters? Like we know 30 millimeters per mercury is the cutoff level for IRP. 45 millimeters, 43 degrees centigrade is a cutoff for temperature. Similarly, a 60 ml per minute is the minimum amount of fluid that must continuously flow through your channel, no matter what your scope you're using or no matter what kind of device you're using, so that temperature is not a question, so that your calyx remains distended. Even when you add suction and aspiration, it should quickly fill up that 60 ml space again automatically without affecting the temperature and pressure. And that is where all the experimental work has been spent in the last 1 year in trying to prove. So I hope that kind of answers the question of what exactly is that 60 ml per minute we're talking about.
Thank you for this explanation, Vineet. Are there any more questions from the floor? So we are right on time, to be honest, and we will continue with the next presentation.
Okay, thank you very much for a good presentation. And we are going on, and next our lecture from Vigen Markasyan from Moscow, raise with funds, please.
So I will talk in English, but first of all, у меня вопрос к технической службе. Я скажу, когда запускать видео, и, пожалуйста, если можно будет чуть потише, потому что там есть сопровождающее фоновое видео. So we move on to the next topic, and today I'm going to present a case of fans, RIRS with fans. But first of all, I would like also to share and express my warm words of gratitude to all people who were involved in the process of putting together such a wonderful Congress. And also it's a great pleasure to be here in such a hospitable city as Tashkent. So it's always my pleasure. So this is the case is about the RIRS with fans, and actually I would call it unofficially the fans. Is it an easy peasy surgery, or not. Of course, to highlight that great and dramatic transformation that our retrorenal surgery, retrograde intrarenal surgery, has undergone during the last decade. So please run the video and we will proceed with our patient. And our patient, as you can see, the video is running. So our patient is a 70 years male with a 5-year history, with a history of stone episodes. So he already has been twice operated. So he had 2 PCNLs, and the recent PCNL has been performed just 1.5 years ago. So he's suffering nowadays. He's suffering with the lower pole stone, which is not a big stone, but middle-sized stone. So it is a 12 millimeters long and with a volume of almost 5 cubic centimeters. And it's quite hard, 1,400 Hounsfield units. So the patient is really exhausted with this surgery, with the urolithiasis. So he's demanding very simple, very reliable, and very minimal invasive solution. So that's why we scheduled him for this surgery for fans. And no pre-stenting was planned since we're using the 11 French size sheath, so which are without any obstacles. It passed through the ureter. So now you can see, this is the video of the surgery. As you can see, judging of the appearance of these stones, we might guess that this is calcium dehydrate stone, and the further stone analysis proved and confirmed our guess. So we work with the TFL laser and with the standard settings such as 1 joule and 15 hertz. Knowing that all the fragments could be retrieved and sucked out from the collecting system very easily without any basketing, with no need for basketing. So it is important to mention that here we don't chase the fine dusting, and we're actually aiming at something in between fragmentation and dusting. Because we understand that we can catch and swallow in the suction funnel all the small pieces, all the small particles that breaks off the stone. So we're just like letting the suction to do its job. And also we maintain a continuous suction throughout the whole procedure, which helps us to keep the visual field crystal clear, and the vision, as you can see, stay unobstructed. Here we don't care about the red repulsion, so nor do we adjust our setting for that, because as you can see, the stone is nicely fixed against the calyceal wall, and nor do we ask for apnea, for the forced apnea here, because we observe a very minor respiratory movements. Here in this surgery, we also didn't use actually the tissue sensor, because it was technically unavailable. Nowadays, it's already available in our clinic, so we just obtained our UMAX laser a couple days ago, so we are just starting to widely use this option. This option is about the prevention of mucosal damage, which switch your laser off once it points at the mucosa. So that's a great option. I guess using this option, we will also decrease the need for respiratory suppression during the surgery. So as the stone mass of the stone debulks, we see larger and larger fragments start to break off. And you also might notice that the walls of the calyceal cavity tends to collapse. It is also due to the pressure, due to the suction, sorry, and here we use gravity irrigation with pumping. Here the assistant plays a huge role maintaining this very, very fragile balance between the irrigation and suctioning, preventing the collecting system from, collapsing. This is a huge role. So, in retrieval of this, so you can see the relatively big fragments might be retrieved via your access sheet quite easily. Just similar the Bernoulli effect that we observed during the percutaneous surgery. So in this case, we also should mention that this is a huge role of the assistant because he have to. This is a very nice quest of cooperation between you and your assistant, who should anticipate all your actions and all your moves and just increase the pressure the moment before you start to pull your scope back.
Can I ask a question?
Yes, sure. Everyone is free to ask questions.
You mentioned the irrigation pressure, but can I ask you about your suction pressure?
So suction pressure, we usually work between 100 and 150 mercury, and sometimes it goes. We raise it up to 200. So actually, when the job is done, and we are hunting. What you can see here, we are hunting for the residual fragments, and we just understand that no lasering would be going on during the surgery, just the retrieval. We accelerate and step up the pressure a little bit, so we increase it.
And in a case like this, for example, if you have a stone stuck inside the access sheet, do you laser it there, or do you find it dangerous to laser it?
Yes, without any doubts. Without any doubts. And as you can see here, there was a couple of examples. Yes, just like this. So sometimes if the fragment won't go, inside your scope, into your scope, so just a couple of hits with a laser would be enough to toss it up toward your suction funnel and swallow it.
But that is actually a dangerous move if you do not hit it in the center, because these access sheets are not as strong as the conventional ones.
Absolutely.
And that heat can melt the access sheet. I have seen those
Yes, could be, but in our cases, they are all, disposable, so we don't worry about this. But
that should be a message for, especially
yes,
for
absolutely. Whenever you can keep on the safe side, you should keep on the safe side. I totally agree. And I guess this is the end of the surgery, and I would like to, I would like to just to show how this 100% stone-free rate looks like in our clinic, in our eyes. So, the suction, it fuels your sense of perfection. And so actually in our case, it, even prolonged the surgery time, because we go on and on again and again through the whole calycis and trying to make it absolutely clear. And sometimes, because you don't want to leave the dust behind, even if a small dust, but the life shows us that the dust might be not that small as it can be expected. So, and the small fragments are found even in a very unexpected corners of the calyceal system.
Can I ask also one more question?
Sure.
Now, everyone is talking about how good this suction is, but no one is talking about any downsides. So can you elaborate on this issue? Are there any downsides? Are there any risks, situations that we must avoid these kind of devices? Maybe there is not. I just want to get your opinion.
Actually, we don't see. Of course, there is a hidden something. So let me show you. This is just a final view of the calyceal system. And actually, thank you for the question, because you're asking a very important question, because we could be in a condition of such kind of euphoria and thinks that this is a perfect solution for everyone. But we also, every time we should think about where are those shortcomings of this technology. And the first shortcoming I can mention is the fragility of this, of this access sheet that are at risk of falling apart during the procedure. So it might happen, actually. And the second one, I actually don't know the influence of the low pressure on the kidney. We know the higher pressure, the more dangerous this procedure. What about low pressure? We don't know the data on it, so actually we don't know. And the third, I would say, it's some kind, this low pressure and the suction. Again, I would repeat, so make the calyceal system to collapse. So after collapsing, they could be observed, we could observe some bleeding that hampers our procedures, not allowing us to continue it.
May I add one downside, please?
Sure.
During suctioning, sometimes this is a problem that I had. Some small fragments are stuck between the endoscope and the access sheet.
Yes.
Then you have to take all the system out and then re-enter.
It happens all the time. It happens all the time because, yes. So, so if you're working, this is the issue of miniaturization, because whenever you have a safe 7.5 scope and 11 French size your sheet, so the gap between the scope and the sheet is bigger and is quite enough sufficient to keep it going without these kind of obstacles and these kind of problems. So I guess we're already done. It's just a few minutes left. This is yes. So this was the final view. So let me summarize. So what do we have nowadays? 100% stone-free rate, 16 to 18 minutes operative time. Patient rendered stone-free with a one surgical session. So that's what we really should call the easy-peasy surgery and a reliable surgery. Again, this is a kind of a magic for me, the technology-driven magic. And I guess going forward will help us to extend our boundaries even broader. And I would like to say that I appreciate your attention and kindly invite all of us to our center, which is a Moscow Urology Center in a warm-hearted city of Moscow. Thank you. Thank you very much.
Thank you. Before continuing, if I may, we have Peter Alkin here, and this is a new technology. Can I please ask your opinions about these new advancements, the suction?
Your
what
opinion?
What are your thoughts about suction on it?
Yeah, I just asked Thomas Schnoll, and he was supposed to give a presentation, will the percutaneous survive? And when I look at what Vivian has shown, I think it will be hard for percutaneous to survive because of two reasons. The size of the stone is increasing that you can do by ureteroscopy. And what we have realized in our country, the more advanced the technique is developed, the patient do not fear to go to the urologist. They come earlier and they come with small stones. And what we have seen that the big staghorn stones went down, the frequency that we saw them. So at the end, small stones, ureteroscopy, and vision, perfect.
Thank you so much. Should we do a voting for the fans?
Yes, voting.
Pros and
Voting
cons.
for the fans.
Vegan.
So
Yeah.
we have one more question from Arman. Thank you, Professor, by the way.
Thank you, Peter.
Maybe this is a little bit of provoking question in a way, but as you mentioned, the downside of these instruments is that, and we're coming from not the West, the best developed countries, there are multiple use of these instruments. I mean, the normal ureteral access sheets, we tend to use it multiple times, at least in Armenian practice, we can use it. I believe in many centers you can still re-sterilize it and use it. but this ones you should be more careful. Have you tried it? Have you used it in your
Okay,
center?
let me put it this way. Thank you for the question or your comment. Let me put it this way. They are officially single-use instruments, and officially they're used one single time. But actually, sometimes we have an urgent need to reuse them. And they're, yes, I'm absolutely true. They're completely fragile, and they're nothing to have, common with the previous non-navigable sheets, because they could be used, many times. So these sheets are really single use, because at the second time you already putting yourself and your patient at risk of some kind of unexpected and undesirable events, such as the sheet breakdown inside the patient.
Professor. Yes, please, Professor.
Yeah, perfect. Vivian, I have one additional question. Thomas Knoll, he commented, when you spend 3 hours for a uteroscopy, and this is not well paid, you're better paid by 40 minutes of percutaneous. How is reimbursement in Moscow for uteroscopy for percutaneous?
I totally agree with you, because yes, it's a very actual and very serious question. So when it comes to time, I mean, you have a very different attitude to for the time. So now we move to the Moscow Urology Center, where something like 14 stone surgeries are planned, and I'm head of department. So my goal is to keep up with the schedule. Yeah. And I understand that time really matters. I said, okay, you should do supine, because it really saves, 10 to 15 minutes. Yeah. You have to do, in these cases, PCNL, because these save time. And additional 30 minutes, it's additional RIRS, one more patient cured. So the times really matters. So in these terms, from this point of view, actually, I agree. As a head of department, I would push my workers and my colleagues to do a faster and efficient surgery.
But how do you push the system that you get a better reimbursement for a long uteroscopy?
So actually, we don't have this kind of reimbursement as a taxi drivers. I mean, by time. So it's not a 1 ruble per hour and stuff. So it doesn't matter how long would you operate. But if you operate long, the less patients you can include into the schedule. So the clinic loses money. Yeah, that's the point. Absolutely. So it's not, yes, the system does not inspire us to use these long but less invasive surgeries.
I think this is a very important comment, because a urologist should fight for the proper reimbursement if we save our patients with good treatment.
Thank you, Peter. I would say urologists never stop fighting.
Thank you very much.
Thank you. Thank you.
Comments.
Thank you very much for excellent presentation, and we are going on. Our next lecture video is a pre-record surgery RIRS with 6.3 scope from Lauren Dragos, Cambridge.
Excellent surgery, Vigan. I loved it, and I was sure you were going to show us that. So endourologists are fighters. Fair enough, but for those of you old enough to remember Star Wars and the amazing series, when we were young, we loved them. We may be fighters, but it's not like in Star Wars. We use all the lasers, but may the Force not be with you. And this is actually exactly the opposite of Star Wars. Now, I changed my presentation a bit, and I have to apologize to the technical team. That was the scope that I was using. It's a 6.3 scope, and in the previous image you saw scopes from 9.3 French down to 6.3 French, and you could see the difference. And I changed things because basically I edited this video a few minutes ago. I had a very nice vegan-like case, and
I decided to go for something different. You won't see lasering, almost no lasering in this video. You are all bored of seeing some surgeons sitting there and lasering. But you'll see an interesting situation that happened to me actually a few weeks ago in a live surgery. Okay, so I was very confident, very happy, very thin scope. I will be able to do everything, whatever I want with it, because this is my standard scope. That's the scope I use on a daily basis. There are a few things that we have to consider about 6.3 French scopes. But going back to the case, you see I've got 2 wires up in the kidney, and you saw the image previously showing that with the semi-rigid ureteroscope, I was not able to go through the proximal ureter. It was very tight. And in the fluoroscopy view there, you could see the tip. You can still see the tip of the semi-rigid scope. Now I've changed, and that's my standard technique. I put 2 wires. I use a safety wire and a working wire. I'm lucky enough to work in a rich environment, let's put it like this, in the UK, where safety comes first. And the next step would be to try to put an access sheath. So having a 6.3 French scope, I was trying to put here, as you see, a 10-12 French flexible tip access sheath. But it was not going up. So the UPJ did not allow me to safely pass, and this is exactly the comment that I'm coming back to. May the force not be with you. So at this stage, I decided, I felt that the pressure that I have to put on the sheath is too much, so I decided that I can't push more. So what is the next step? As you can see on the fluoroscopy screen there, the first thing that one should do if you have a wire alongside the sheath in the ureter, that's as a safety wire. At this stage, unfortunately, you want to give up on your safety wire. So there are not 2 wires anymore, there's just 1 wire, and that was the working wire. Despite of taking out the working wire, the sheath was not going in. Remember, last live case. What's next? Okay. Retrograde says Emre. Correct, retrograde. We did one at some point before, but anyway, you can see the stone is very visible. I was very confident. I've got a thin scope. I've got a wire still in. I left the sheath where it was, and if you were paying attention, you saw that though I was not forcing too much, the moment when I came out with the introducer, the sheath moved backwards. But it actually did not move backwards in the ureter. It was just the part that I was still pushing. The ureter is an organ, is not a tube. Don't think of it as a tube. It's an organ. So the ureter was moving with me, with my movements. Once I left that, it was just coming more or less in the same part. So this is where the flexible scope over the wire didn't go through. I felt pressure. If I put too much pressure on this scope, it's not working. So what next? What would you do next? I'm going to ask my wonderful chairs here. I've got a 6.3 French scope. I've got a wire in the kidney, but I can't go forward.
And you don't have any endoscopic view? This is the endoscopic view?
This is the endoscopic view, yeah.
So, I guess, I would just put a double J stent and abort mission.
What I didn't tell you, this patient was pre-stented.
He was pre-stented?
She was pre-stented.
What was the size of the stent, of pre-stented stent?
It was 6 French.
6
stent.
French, and now you can pass with the 6 French.
And I've got a 6.3 French ureteroscope, and I've got a wire. So there was a bit of, I did try to put a bit of contrast in there now, as you can see.
In such a cases, I would say that...
I'm trying to go over the wire, you can see on the endoscopic view. So what next?
Have you tried to put a second, another guide wire in order to, this technique over these 2 guide wire to just push the walls of the ureter, wider and pass through this obstacle?
Remember, I've got an access sheath which is a bit lower down in the mid to into proximal ureter. I've got a wire through the access sheath because I gave up on the wire that it was the safety wire. And I've got a scope over the wire. I put some contrast because my first thought was, isn't it? I've perforated. I've done something wrong. I've pushed the sheath despite of trying to avoid that. I pushed the sheath. There's no perforation there. The fluid goes in there. Now, there is this thing, and I won't recommend this for the unexperienced surgeons. This is the moment when the young guys doing ureteroscopy should go and ask for more experience for a senior colleague. Because this was a live case, and my decision at this stage, because I saw that there is a path up in there, which is a bit counterintuitive, to give up on the wire that doesn't allow me to manipulate my scope in the way that I want. So now is completely no safety wire, no wire in the kidney. I gave up on exactly the thing that all of us are taught not to on your last resource, the exit. But knowing your scope and knowing that the patient had a stent there, so there should be a way up into the kidney, I gave up the wire and I went into and being able to manipulate the tip of the scope through the tight part, and I ended up getting into the kidney. Comments?
Such a cases, did you or do you try to dilate the ureter by inserting, for example, urethral catheter, something like 7 to 8 French, in order to secure that ureter is already dilated, so you can, go through and break through this obstacle safely?
I'm not a big fan of dilating actively the ureter. Passively with a stent, that's fine. But going and trying to dilate it like we used to do it 15, 20 years ago, I'm not a big fan. But I carried on because I was quite confident that actually there is not such a big problem as you would think it is. But now I went into the kidney. Remember, I still have an access sheath, a flexible tip access sheath, but it's not in the kidney. It's somewhere in the mid-proximal ureter. And this is the image in the kidney. What can you make out of this image? Is it a good view? Easy to say no. But what else happens here?
Is this a question for us, for the audience?
It's a question for anyone who wants to pick the answer. Now, the whole point of me showing you this image is about the pressure, about all the things that we've discussed so far. When you see this, it's what I would call a standstill. There's no true, it's the movement of the scope, but there's no true movement of the particles, either in front of you or behind of you. So what does it mean?
No irrigation.
No, I had irrigation.
You have irrigation?
Obviously,
No,
yeah.
there is no outflow.
Irrigation is running,
which means
but
that
it's a standstill. So this is a very good lesson for the young guys. You think, okay, everything's fine. I've got irrigation. My bag is at, let's say, 60 centimeters from the kidney. The line is running, so everything is good. If you start operating in this, you're in trouble. Because if we talk about temperature now, this is the moment when you can actually cause temperature damage. It means that you have inflow, but the pressure has reached the pressure limit. It doesn't mean that if you have the bag at 60 centimeters from the kidney, the pressure inside the kidney is going to be 60 centimeters. It means that it cannot be more than 60 centimeters. What's inside, it's difficult to know without a pressure sensor, but what's important, there's no flow. Nothing goes in, nothing goes out anymore, because the pressure has been equalized. Okay? So when you see this, you don't carry on. You need to change things one way or another. And then my decision at this stage would have been either I stop, I don't go ahead, or I try and gently advance the access sheath over the scope and seeing if I can make it in. And when you advance the access sheath, I have to thank again to Professor Alken, you don't just push it. You don't, when you do a PCNL, you don't just put things in. You need to feel, and you need to do these small movements of half rotation and advancement and feel the tissue. Advancing it over the scope, even if it is a 6.3 French scope, not a large one, and the sheath was 10 to 12, yeah, so 10 on the inside, 10 French on the inside, 12 French on the outside. It still allows you with a, remember, it's a soft tip to go over. So I've managed to put the access sheath into the kidney, and look at the image now.
Yeah, it's better.
It's a completely different thing.
Yes, and which size of the sheet do you
10,
use?
10, 12, that's
10
what
to
I said.
12, 10 to 12.
10, 12.
But actually you said you don't want to dilate actively? What
I
is
did
it.
it.
If it's
That's
not,
exactly.
So it's a strict,
was,
I mean, active dilation. I mean, when you're passing the access sheet.
Exactly. So I'm not doing this routinely, but then it was either I try it or I stop. The patient has been pre-stented, so it would have been putting a stent and coming back would have been coming back to exactly the same situation. Nothing would have substantially changed, and it would have been probably left in someone else's hands, more experience, less experience, I don't know. But I thought I can try, and I can. I have enough experience at this stage in my career to say
to take
I am
the
pushing
responsibility
exactly,
for
and
this
to
case.
say I've pushed too much, or I am pushing too much, or I'm not pushing.
And in this type of situation, you should realize that otherwise you should work gently. Otherwise, you should be providing some new cases
Now,
for the Said Ben Hamri presentation.
I would have ended on Said's slideshow. One more thing, one more comment here. You see, I was staying a lot there. Now the fragmentation has been done. I was staying a lot there. I did not start lasering. Why?
You didn't stop laser?
You didn't. I did not start lasering. There was a lot of standing there and looking at the stone. Why? Why wasn't I happy? Because there wasn't space. So the inflow against outflow was not well calibrated. So when the calyx closes over the stone and you don't have space, it means that what goes out is unbalanced compared to what goes in. Now we will have the pressure sensors, but with or without them, we need to have space to work. So we had to increase the inflow to be able to open a bit more the space in the kidney. We have to do it on the safe way as well, and that's what the pressure sensors, why they are helpful. Now, that was the last trick that I wanted to show you there. If you have these tiny residual fragments that are attached to mucosa, then you don't need to go and laser on them. If you put your sheath over them and laser in their proximity, the flow and the laser energy will just take them out. And you could see the question during live surgery was, why don't you try, get a basket, put the stone somewhere else? Why are you working in this acute angled calyx? It's a very good example to show you that this scope has a very good torque and is able to torque a flexible sheath even in an acute angled calyx, and you can still work in this situation. So more or less this is how things were looking at the end. It was a bit of a different case, probably not what you've expected, but I'm happy to take any comments for the last minute.
First, a big applause for this hard case. These are always complicated cases where we should be very, very careful. With your expertise, okay, it's acceptable that you're trying this, but of course we should keep in mind that mini PCNL is an option in these complicated. Instead of causing a bigger trouble, we can refer the patient or schedule for mini PCNL or risk and take the responsibility.
On the micropipe PCNL, yeah, this is still an option. I think we don't have time for the question. One brief question from in command from Nariman, and we move on, very fast.
Lauren, great case. Thank you very much for the tips. Do you think it is quite safe to advance the access sheets over the scope I mean, why don't you take obturator, because it is made for it.
So you remember, I did try over the obturator and it didn't work.
Okay.
So definitely that's not my message. My message, there are two messages here. First of all, when you get into this situation, if you feel that you're not safe, you stop. But if you have someone more experienced available, go and get some advice. Don't, because I know I come from a different culture and I'm working in the UK culture. I know that probably in our part of the world, going to someone else and asking for help is not something that we like to. Forget about this. There's always someone better and more experienced than you. If you have that person with you, go and ask for help. That's one. Two, learn when to stop based on what you see and what's your experience. Three, never force. You can only force based on your experience and judgment. This case could have ended easily on Said's list.
Thank you. I think we should
conclusion.
move
Thank
on,
you.
and I will present the next speaker, who is Arman Saturian from Yerevan, Armenia, with a presentation, Ureteroscopy Managing the Challenging Cases. So the floor is yours, Arman.
Thank you. First of all, thank you very much for the kind invitation. I'm pleased to be here on the stage. And probably your case could be one of the cases of managing the difficult cases. As one of the comments or one of the ideas, would you have tried to go over the stiff wire to advance it? Have you tried, Lorian, to go over the stiff wire?
Sometimes they are very good to straighten the ureters. But again, here it's a problem of how delicate and how much you push. At that moment I had a hybrid wire, so the stiffness was good enough for me. It's a bit different compared to PCNL. You have to be even more careful with the ureter. So yes, to straighten, but not necessarily to push.
Okay. So let me start the presentation, and let me start with the pictures. These are the pictures from a wonderful city of Patras, where I did my fellowship. And this is a picture from 2019. Why I put it this, not our faces, that we're young and we're very happy. You can see the hospital behind us, and you can see the hospital behind us in 2025. The hospital is the same. The images are the same. We are a bit older, but still, this is not the best hospital that I have seen in my life, and definitely not the best if I'm also comparing for the Armenian hospitals. But what we had there was the wonderful department of Professor Leatskos, and with the equipments done in an interventional radiologist-like kit, you can see everything hanging on the walls. So every instrument, every guide wire which was needed was there accessible. And due to this, there were a couple of recommendations or dogmas for me for the whole life, that you should standardize your cases, and you should reduce, why we're standardizing the cases, to reduce the number of complications, and on the other hand, to understand and identify the source of the complications. So, and this is a quote for him, and I took it, that if we should not think during the normal cases, during the standard cases, and we should think how we are dealing with when we have difficulties or complications. And when we want to treat challenging cases, we should be prepared, basically. How we are prepared? We have to know our instruments. And basically, in endourology, we should know what the best instruments we should have are the guide wires. In this picture, I tried to picture to put together the guide wires which were used in the Patras, and the ones that I also took to my center. So you can see the hydrophilic ones, the tipped hydrophilic guide wire. You can see also the hydrophilic stiff. In some cases, you need it. The hybrid guide wires with the hydrophilic coating and with the PTFE coating for the rest. The stiff, super stiff, extra stiff, basically done for the PCNL punctures. And here are the catheters which are also very needed to understand. The ureteral catheter, the dual lumen catheter, which is a wonderful instrument. You can have both 2 guide wires going in or 1 guide wire and the contrast medium. The arrow, which has a longer tip, and the you can easily, not easily, but I mean you can go into the ureteral strictures when you have a prolonged stricture. So this is a wonderful instrument to go in, and you have the possibility of having 2 guide wires and also a contrast media. And what it is important in also the last ones, the 4 French angiographic catheters, which are the fully hydrophilic from inside, fully hydrophilic from outside. So basically, you can slide over the hydrophilic catheter when you have troubles of advancing 6 French ureteral catheters. And this can be a lifesaver. And also we have the new technological advancements, the fans, these scopes in the second picture, as you can see, with different differences in the working channel diameters, 3.6, 5.1. We have the automated irrigation pumps. We have the stone sense from Professor Traxler. What it is also essential to understand when we're thinking about the instruments we have, also from the Lorient's talk, that not all the fans and the outer sheet of the fans is the same. So basically, the clear Petra, you can try to advance it because it's more flexible. And Nariman also, you mentioned how it is possible to go over it, right? Is it safe to go, not to use the obturator? In some sheets, the outer sheet, you can really manipulate with it. The other ones do not fold, so advancing it over the scope could be difficult. So let's go to some of the cases. Here is the case of the fans and this. Why, in my practice, normally I'm using now the fans plus this, and this is the case why you need it. You can see here, for example, that using the fans, I cannot go into the calyx easily because there is the smaller infundibula. In this case, obviously, going with the fans into the small calyx and not advancing going with the disc and not advancing the fans is a good idea, and you can see that you can clear the whole dust and improve the visualization only using the disc scope in this case and without any harm to the calyceal infundibula. Also, we have the color adjustment features of the scopes. This is just an example of one scope, so you can see that there is a difficulty of visualization of the stone. The colors are not the best. What you can do, you can try to modify the colors, and by modification you can see the stone in a better way. Now you can see the colors in a brighter way, so you can differentiate, and if there is some of the bleeding, you can still have better visualization. So the aim of the current presentation is to make us think during these 20 minutes. And let us think. I think that also Vigen and Emre would help me in these challenging cases. So when we have the challenging cases, we can also improvise. This is a patient of, I don't remember, 23, 24 years old. He has 2 stones in the lower pole and heavily dilated system because of the ureterovesical junction stenosis. Can you see the stent and can you see the stones? I mean, having the image of this, probably I had the feeling that I also the distance is very
long,
much.
yeah, and we couldn't reach unless we use the passive deflection. In some cases, it might work, but yes, this is complete improvisation. So you're going in not knowing what would be the next step of you.
Right. So also I warned the patient that maybe this would be non-helpful, the procedure, and I may come out of the procedure telling him that, you know, it was unsuccessful. So this is the case. I want in heavily dilated system, as I told, with a fans scope, with a fans sheath. You can see that I can do the, I can see my sheath itself. This is normally
complete
done.
Round, complete circle.
So now you can see it's going. I tried to relocate it. So this is the idea before going there with a basket to try to relocate to another position. And I was lucky enough to get into it without reaching the stone. from a further distance, and here you have, you know, the 2 division, not the 3 division, so you don't feel the depth, how deep you are going and touching the stone. And I'm trying to relocate it. Where would you relocate? To the upper calyx? Really? I tried, but I thought that it would be better to relocate it into the ureter. So it was a highly dilated system. You can see the ureter. I mean, this is the middle low part of the ureter, and this is very dilated. I have a lot of space to work. So having all the system, I thought that having all the stones in the upper pole, they might run into the lower pole, and I would not be able to clear the stones. So I brought into the ureter, I went for a dusting mode, low energy, low joules, and afterwards using these parachute baskets helped me to take out the fragments in no time. The surgery lasted about 15-20 minutes without any residual fragments. So normally what you have in the ureter, if you have the ureteral stones, if you have difficulties, what is the recommendation? To push it into the kidney and to work with the flexible scopes. In this case, since it was heavily dilated, I thought that if I break the stone inside the kidney, I would have troubles of taking out all the stones, and I cannot reach the lower pole, as you can see. So, coming to the another one, when negative urine, we know that we should have the negative urine culture before the URS, before the rears. But sometimes it is impossible to reach the negative culture. Have you had such patients that the culture was positive even after a couple of races of antibiotic treatments? And this is a patient, a 52 years old male with diabetes mellitus. He was a Yedova witness, and he came to the hospital with fever, nausea, so double J was placed. And afterwards, we had 3 consecutive urine cultures and 2 months in 2 months and with repetitive treatment. So basically, after this also, the urine culture was not negative. It was still positive. And the video is vice versa, but there was a bulk of the stone in the pelvis. So what would be your opinions on this?
So that's I guess this is a never-ending story and topic, because unfortunately we don't have even now clear evidence what to do and recommendation what to do. In our clinic we have a protocol, and we noticed, so we analyzed our data, we noticed that by trying to give more and more antibiotic courses, you were just like developing the resistance of the flora. So it's better to give an antibiotic course prior for 4 to 5 days and go with these high levels of antibiotics rather than wait for until the urine culture would be sterile.
That's similar in our practice. So we take the patient to the ward a couple of days prior to the surgery. Under antibiotic suppression, we continue with the surgery. And also, it is important to take cultures during the surgery from the collecting system so that you have an early result. The urine culture from the collecting system plus the stone culture. And if there's a stent inside, also stent is sent to the culture. So you have different results and you can act proactively. And in the early postoperative period, we are a little bit, it's easy to do this in Turkey. We ask for acute phase reactants, CRP and procalcitonin. Procalcitonin is so sensitive for predicting sepsis cases. So we follow the patients up very closely with these acute phase reactants.
Right. And obviously you could consider here to do PCNL, but since the patient is, from a risk group that you don't want to have a bleeding complication.
So he's a double-edged complicated patient, so he's at the risk from both sides. So he's a very nice candidate for the sepsis, and he's a very nice candidate for a bleeder who cannot afford the blood transfusion. So that's a quite challenging situation.
So where we went, this is the new automated irrigation system, and we knew that it should be safe, the pressure should be low, and you can see that this is the case. You can see that there is a lot of dust, there is a lot of fibrin, and the automated irrigation system gives us the possibility to irrigate and aspirate at the same time, and you can see the pressures. On the right, on the screen, on the system itself, you can see that the pressures are 6. There is a limit of pressure that we can have. You can see the visualization is good. The whole visualization is good. It's done with the irrigation, continuous aspiration, with the intrarenal pressure of 6 millimeter hydrorhium. Sorry. There is a limit on the system also. You can limit to 30 mercury pressure or to higher pressures. At some level, we tried to feel, I tried to see if I increased a little bit the level of the safety level on the system, would it go high? And you can still see that the irrigation, the pressure inside the kidney was not more than 20 millimeter for the whole case. With the big bulk of the stone, we were really safe and finishing a case in 15 minutes. So the recommendation here would be to be safe, to be short, and to know the instruments you have in your hands. Basically, the instruments which gives you the possibility of aspiration and irrigation. This is a wonderful candidate for this kind of a system, I suppose. Going to another one, when retrograde is not an option, it's not that we have to do always retrograde for the ureterorenoscope, for the ureteral stones. In this case, we have a 56-year-old male, complete duplicated system. The ureters fuse at the junction of the arterial crossing, and there is an impaction of the stones. So basically, he has failed before he had 2 attempts of URSs in another hospital, and the patient was referred to me. He had the percutaneous nephrostomy, so we tried to go with the antegrade approach. We put, normally I would consider of puncturing if I'm doing the PCNL. I would not use the same tract. In this case, it was a 12 French nephrostomy. So I thought that, going directly to the stone from the same nephrostomy tube could be a good idea. Using the dual lumen catheter to place the second guide wire, the principles are the same. You should be safe. You should have both of the guide wires inside the ureter, and you can advance either the flexible ureteroscope on the guide wires, or you can go directly with the access sheet, and the flexible access sheet can allow you to do the same maneuver. In this case, it was my flexible ureteroscope, and I went from the same opening, from the same nephrostomy tube down to the ureter without an access sheet. Just over the stiff guide wire, you can push it, you can see it's going down, and having the safety guide wire, having the flexible ureteroscope inside the ureter makes your things really good. You can see now that the stone is really impacted, and having the flexible ureteroscope inside the ureter, it doesn't mean that the surgery is going to be easy, because at the level where the stone was, it was on the arterial crossing. So I could also see the palpation, the pulsation of the artery, and it was really not the easiest case, even with the flexible ureteroscope, because the angles were not very easy. So I have to remove the guide wire during the surgery, because it was limiting my movements. After some point, of course, the meaning is here not to dust. The meaning is to break, to be able to break the stones, and having the antegrade approach is a luxury thing in ureteroscopy, because you can have so much irrigation as much you want, because the way you are not going to move the stone back into the kidney, you are going to move the stone to the front, you are going to push it into the bladder. So this is a luxury thing that we can use during the antegrade approach. And if you have haven't ever done the antegrade one, I would really recommend it to do it because you will love the surgery. It is fast, it is easier in a way. If you are not, of course, afraid of the punctures and you have already the access, then this is a piece of a cake. You can see that after the stone is gone, the ureter is dilated, and you are not messing up with the other ureter, with the other ureter from the kidney, so everything is relaxed in a way. You have some stone fragments which you can push, or you can, with the irrigation, you can help to irrigate into the bladder, and again, you are not worried that it is not going to be dislocated into another part of the kidney. You are free, you can see the balloon, so it is done, and you are not caring about the stone-free rays. It is stone-free.
A rare situation when the retropulsion becomes your friend.
Yes, this is for sure a friend for you. So, beginning difficult, whole surgery difficult. Probably this is not the surgery I'm very proud to present here, but still, since we're thinking about the challenging cases, if I had the better images, this could go to the CAEC list, but I was not planning to have the complication when I was doing the surgery. So male patient, 50 years of age, dysuria, difficult urination, no preoperative surgery on the urethra. He was a soldier for 2 years, and he had 2 bilateral stones, one on the left side, 8 millimeters, and on the upper and lower part, and upper stone in the right ureter. And he had residual volume. So during the procedure, we identified the panureteral stricture, and I was not able to advance the cystoscope, so the rigid ureteroscope was difficult. I passed it with difficulty. There was hypertrophy of the left ureter orifice and tight right ureteral orifice and tight ureter. So the plan was to perform, at least before the surgery, the plan was to perform the left-sided stone removal, and if possible to do it if it was fast and without any things, then to perform also the right-sided. So we went in. You can see the orifice, hypertrophic orifice. The left part was done as planned. I went in. The images are not good. I told you that I would love to have the better images if I knew that there is going to have this kind of complication. Still, the left part, I was successful to remove the stone, and I was happy. I was trying to go for the right one, and I'm filming it. This is a not professional one. I'm showing how you can go, like to my resident, how you can go without the second guide wire, trying to adjust a little bit the ureteral orifice, playing a little bit with the ureteroscope if you have tight ureters. I have one guide wire, one safety guide wire, and normally I would do with a second guide wire as I was trained over the second working guide wire. Here I was a little bit in a fancy mode, so I tried to go without any guide wire, and at some point I was so into the playing mode that I pushed more than I wanted, not over the guide wire. And here in the upper part of the ureter, I had the perforation of the ureteral wall. And you can see the extravasation. After I tried to give some contrast, and there is no filling inside the kidney, but there is extravasation outside the kidney. And this is the sad part. I cannot advance any cystoscope. I have only my ureteroscope. These are the conditions. I have the standard hydrophilic guide wire, cystoscopy not possible, and complete contrast extravasation. And one more thing, he was a friend's father, so I was intended to do the best out of the procedure to come out of the stone-free in a single session. So again, what would your comments? How can I proceed with this?
Any comments from you, Professor? Any comments for the case? Well, for starters, I would. If you have a guide wire, I'm just wondering if you can advance a dual lumen or a ureteric catheter over this guide wire. Is that possible? So if you advance it up to the point that it goes, maybe you can have a contrast injection at that point. That would be my first
idea, I went with a dual lumen. I didn't want to push. I just went with a dual lumen, gave the contrast, and there was complete extravasation, the whole contrast media. So since I had the hydrophilic guide wire, I was really afraid that if I lose this hydrophilic guide wire, I can lose the whole access to the kidney. So what I did, I used the 4 French angiographic catheter to have less effort on the guide wire when I was going in. I changed the hydrophilic guide wire to the stiff guide wire, and over the stiff guide wire, I was able to advance the dual lumen catheter inside the kidney and have the second hydrophilic stiff guide wire. And with this second one, I was able to advance the stent over it. But basically, what it is what you have to have in your mind. You should remember what cases you have, and lessons learned is always that, never overestimate you and never change the rules in endourology. Standardize and follow. And like you can see my friend Lorian here sitting next to me, and his quote is that endourology is easy until it gets difficult. So this is the same. If you have difficulties, you will have the difficulties during the surgery. The second lesson was have a safety guide wire. Again, a talk before was like you can sometimes modify the safety guide wire, but if you are not sure, have the safety guide wire and it will save your day. And the third one is to know your instruments in your hospital, in the OR you are working, and know which instrument can be the life-saving instrument. And the most challenging cases for me, and not only for me, I believe, are the cases with encrusted ureteral stents. And the last video, this is 5 minutes video, sorry I'm going to be a couple of minutes before, late, but still I want to show the video. This is the video prepared by our team when I was still in Patra. So basically, the lithotripsy of different parts of the encrusted stents. This is the easiest one. If you have the incrustation inside the bladder, you don't have to think about it. You can break it with the laser, you can break it mechanically, you can break it with a ultrasound or with dual energy lithotripters. So basically, what you have to do, you are just breaking the incrustations and you are taking out the stent. Not a tough one to do, obviously. And the incrustation, we should remember that the incrustations mainly are soft incrustations. If it's not, of course, left there the whole several years inside the kidney. So after you have done with the bladder incrustation, you can take out the whole ureteral stents. If we're dealing with the middle part of the incrustations, it can happen. Here in this case, for example, you can see two stents. When you have the incrustation of the one of the stents and you cannot advance into the system, you could consider restenting and passing the second stent into the kidney, which would give you access again with mechanical dilation and advancing the scope inside the ureter afterwards. And after you break, you can come out with the stents itself. Considering the incrustations in the proximal part, again, you can go and break it using different energy. You can try to break it with a rigid instrument. If it's like in direct access, I would recommend you to work with the flexible one, but consider that working with the flexible one when you have the double J in place could be difficult in a way that it might limit your movements. If you have in the upper proximal part of the stent and you can break it with a semi-rigid one, remove the stent and then you can go in again with the flexible scope. Again, the modes of the lasering could be different. The main aim is to take out the stent, and once you have you have taken out the stent, you have the possibility to go with a flexible scope and work in a wider working space. Several other practices that you can do. If you cannot remove it in one piece, you could consider cutting the stent in pieces with a laser fiber. If you can see, you cut the stent, you remove the stent, the part of the stent, and you go in. Again, you have a wider working space for you. What you can do also, you can advance the ureteral access sheath
and try to remove the pieces of the stent through the ureteral access sheath without damaging the wall of the ureter. In this case, like for example, we had the part, and then afterwards we were able to advance the ureteral access sheath to the level of the encrusted stents. Then again, cutting the part. We can see it here. Removing the another part, again, like part by part, removing the stent and advancing into the kidney. You can see that when you have the stent inside the ureteral access sheath, you are more or less safe, and you can see that the incrustation is really a bad incrustation, an incrustation that can damage the ureter. And afterwards, the leftover, the proximal part, again, you can go with a flexible scope, try to catch it and bring out with the same ureteral access sheath which was placed before. And in the last case scenario, when you cannot remove it retrogradely, you can go and try to do it with a percutaneous access. Of course, you don't have to do a non-papillary puncture, but you can consider that non-papillary puncture is also safe for performing PCNL. Thomas Knoll is here. Probably he would comment on this afterwards. But yeah, I was trained in the school.
Don't go there, man. Don't go there.
No, I should not talk about it. It's not the way to do. In every cases, I cannot tell that I'm doing non-papillary in every cases, but still I know that, there is a literature backing me up for the non-papillary, and when I have troubles, I can consider this. And obviously, when you have the encrusted stent inside the kidney, a big bulk of the stone, doing a PCNL could be an option. So, consider both retrograde and antegrade routes. Single session procedure can be performed in most of the cases. This integration of incrustation can be achieved with different devices. Cutting of the stent enables wider working space. Ureteral access sheath can reduce damage of the ureter. Additional dilation of the ureter with the additional placement of the ureteral stent can be done. So in conclusion, be prepared for difficult cases means that you should be equipped with needed instruments, you should plan beforehand, and you should have a plan B. And do not underestimate the importance of the safety wire. And I kindly invite you to the first inaugural Congress in Armenia, which will be held 17-18 July this year. Thank you very much for the possibility.
Thank you, Dr. Tsaturian. Unfortunately, we're running out of time, and we cannot just take questions. Please announce the next speaker.
Our next lecture is the dark side of the the dark side of ureteroscopy, Said's collection of complications.
Dr.
Yes,
Hamri
I started hit
would dive us to a darkest or part of the. Should we announce that if there is a heart fainted and sensitive guys that they should leave the hall? Said.
Thank you very much.
Please go on.
To stick to my name, these nightmares. Assalamu alaikum, first of all. And I'm happy to be in Uzbekistan, Tashkent again and again. So this is going to be a joyful journey for you because you're seeing a beautiful operation and you think this is life. So I will criticize. These are my declaration. I work with these companies. So first of all, we have to know that the most important nightmares comes first from prevention. And if you are inside the trouble, you have to think about troubleshooting. Endourology is troubleshooting. You have to be fast and you have to be wise. We will discuss the indication, the larger scope, lasers, guide wires, access sheet, baskets, pressure, and written material. Let's go for the indication. Look at this stone. Maybe Peter Alkin will see this. This is a 2.5 centimeter, 2.3 volume CT scan. 2 weeks later, all the volume of the stone dispersed in the kidney, and the aim of the surgery is to eliminate the stone. So if you don't do it right and do the dusting, fragmentation, elimination, you failed. So this should be a message for the young that the flexible ureteroscopy is not always the savior for you. You have to do it right. You have to deploy it right. Otherwise, you'll have these troubles. These all stones, when it comes to the ureter, these are rocks ureters, full of the stones. So you have to spend time to remove these stones from the ureter. And it might cause a stricture and insult to the mucosa. You can see these pictures again. We have Steinstrasse after the ESWL. Now we have this Steinstrasse at the beginning of the flexibility scope. So elimination is important and do it right. If you are unlucky, this kind of a stone with the too much pressure, and you leave the patient for 4 weeks, you think this stone will be eliminated, this stone will comes behind the mucosa. And I call it paved bricks. It's like the paved bricks in the streets. And you see, every time you do the CT scan, you'll find the stone. The stone is behind the ureter because of the pressure and the insult of too many volume of fragments. Larger scopes is not anymore a choice, but larger scope, if you force them, you might go to the retroperitoneal space. You look at these pictures. So do not force. Force is a subjective. It's not you, it's not your other residents. So everyone has his force, has his brain to work inside the theater. Go smaller, even a small scope. Do not force them. These are very tiny. In Middle East, we have the very tight ureters. Look at these injuries, even with it. These ureters are 3 millimeter, 3 French. The most difficult ureter, the diameter is down and the junction, and we will see now why we have to take care of this entry. It says our entry, we have to respect it. Now, if you go to these kind of partial avulsion, urinoma, you have to put a nephrostomy, you have to drain by a drain and get out of your problem. If you are lucky, you will never have some sort of structures. If you manipulate upper ureteric stone 5 millimeter with a semi-rigid, you think that's semi-rigid, and you turn on the semi-rigid. Semi-rigid is like it will take the ureter, it will twist the ureter. This is a sausage ureter because of too much manipulation by the semi-rigid for 5 millimeter stone in the upper ureter. And this patient has to go for complete replacement by the ileum. Look at these avulsions. I received it from friends. And I received a patient, the ureter is not visible, and you can see this recently, I put it in WhatsApp group, the patient, I don't know how this happened, maybe something wrong with the force or the ureter was tight, and sometimes it's not necessary to happen by the semi-rigid, it could happen with the access sheet as well. So you have to think about the hydrophilic and the feeling. How do you feel the force inside the ureter? Ureter is very small, huh? So do not think this might not happen to you. Do not hesitate to leave a stent. Do not apply too much laser to the ureter. If you are lucky, do not touch the whole circumference of the ureter. And you have to think always about the irrigation. You can put 6 watt, but in this case, 16 watt in the ureter, the basket, the laser fiber inside the working channel. So you think you are safe of the laser. By the end, you will see this picture. The complete burning, the circular burning of the ureter. So it's too much energy, less compromised irrigation, and you will end by heat. And then you will find some strictures. Let's go for the proper, as we heard Professor Traxton say, hit the center, do not touch the mucosa, work with 5 pulses, 6 pulses, you will save. You will see a reddish edematous reaction. This will go fine with you. Otherwise, you can see different of strictures. As you can see, this is a 2 centimeter in the mid of the ureter, too much heat, 2 hours of operation, and then a complete ugly face of the 2 hours lasering, 3 hours for 2 centimeter in the ureter stone. So you have to do it right. Do not think the laser, you have a big machine, you have too much pulses, you have to hit everywhere. No, this is a 26 years old male. And he has both strictures because 1 centimeter, 2 centimeter, when we took the appendix and the other one went to the direct anastomosis and the buccal graft. Let's go to the ugly face of excessive heat. Again, another stricture. Do not think the life is easy and always. So you have to respect. And I think it's not about the companies, industrial hosts pushing you. It's about your training. It's about listening to the professors who have the experience. How do we deploy these? This is a 30 watt in the kidney. The surgeon, when I talked to him, he said, I apply 30 watt, too much pulses, but he reduced the irrigation, so the heat is all over the kidney. Kidney is burned. And this is again a patient with double strictures. When I discussed with the urologist, and he told me it was 1 centimeter stone, but I don't want the fragments to go up to the kidney, so I closed the irrigation. So he put 6 watt, but he closed the irrigation because he was afraid that fragments go to the kidney. As you can see, these are two double structure went to the reimplantation. Again, a live picture. You know, these cases are not reported, and this is the problem that we are happy about the successful. But this is a patient, 25 years old, no access sheet, big scope, 9 compromised fluids, the complete renal bulbus disappeared. As you can see here, he applied 40 watt without irrigation, and then you will see only the lower calyx. Now, if you think that the endoscopic alignment could be better, but if you see these kind of structures, this is an antegrade view, and you can see the symergid there, and all false passages that you want a realignment, it's not good. You have to go for reconstruction. Do not waste your time, waste the patient time. And again, laser lithotripsy. This is a spinal anesthesia. You want to hit the stone, but suddenly patients under pressure, you hit the kidney, and it looks like a PCNL. So the kidney explodes because you don't respect train under spinal. I know most of the patients, they want spinal, or the surgeons because they want to save money or it's easier for them, but think that too much pressure hitting the laser, the kidney will explode. Again, this is a laser incision of the diverticulum. I remember a case, a Freley syndrome, which is around the neck there is an artery. Then you cut it because you want to cut it more, not to have a recurrence stone of the patients. The patients will go for angiography and embolization immediately and transfuse maybe 4 units, 3 units. And then this is only incision slightly. When you go suddenly in the kidney, you want to start and suddenly bleeds. So this one I posted on Twitter. I don't know what's the reason, but it could happen, but it was a nightmare. And then we did an angiography. It was normal. The patient stabilized in 48 hours. So do not think that the flexible always there are good images and good live, but this was a scary, scary thing and a very nightmare for me for 2 days. Now, guide wires everywhere. So you have to make sure that the guide wires in place. You have to do proper retrograde pyelography. Make sure that your guide wire, especially for impacted stone, do not put the guide wires, you think it's the kidney, and then you slide it over. So always guide wires, think that the track of the stone in the lateral part, not the medial part. You can use some of tricks, the whistle tip, you can use a coude, and you know that the stone in the lateral part. Now, if you have any difficulties, do a PCNL, and as Ariman showed, that you can go from up and destroy the stone and finish the case. Guide wires outside the kidney, you have to make sure that the guide wire is hydrophilic, but it's your force. You want to put guide wires everywhere. Guide wires out of the system because of the fornix rupture, and the guide wires outside. Look at this picture. Guide wires everywhere. It's like an electrician. He's not an endourologist. Pushing all the wires inside the kidney. Another guide wire. All guide wires. Pushing the symergid inside. Go subcapsular. So it's about the force. It's about understanding these are very small organs and very sensitive. This is a patient's ureteric stone, and then the double G stent was in the parenchyma, and the stone was not treated. So do not insult more in your patient. Do not do double G stent without X-ray. I know some people, I'm against that. There is fluorosis or something like that. You put the stent behind the spleen. You can put it in everywhere in the organ. So make sure that your stent in place. Work with the fluoroscopy. It's fair safe, especially for the beginners. People, they are talking, okay, we are talking about fluorescence, no X-ray, but it's must in your early life, and then you will learn. And sometimes you can put the stents in the subcapsular space. I don't know how did that happen. When I received this patient, I said, where is that double G stent? We could do laparoscopy or nephroscopy, so I decided to go up. I found the tip of the stent behind the renal papilla. So you will ask yourself, how this surgeon put the stent hole outside the kidney and the tip of the double G stent behind the papilla. We were lucky to see the tip, and we just pulled it by the engage. We were lucky to have these kind of baskets. Again, access sheets, since the publication of Oliver Traxler in 2013, where the injuries in the ureter was blamed of the access sheet. I think you have to deploy the access sheet in the right way. Otherwise, you will go in a forced passage. Look at this access sheet without the guide wire. Why do you push the access, not a scope? You have to make sure the guide wire in place, especially in slippery place, or you perforated the ureter. And you can see that the force happened into the ureter. And I think we have to stop talking about going smaller with the scope, but you going bigger with the fans. Because you are using 7.5, but you're using fans 11. So I will come to that later. I will explain to you. So this kind of injury is horrific. And this is the forcible penetration of the access sheet without X-ray. You put the guide where you think you are any side, but in fact you are in the retroperitoneal space. And this is the complete picture of it. This is no guide wire, big access sheet 12-14, and the ureter is losing. You are losing the ureter. Ureter escaping from you. So no guide wire, big access sheet, and you don't know where you are. Okay, so the ureter disappeared. So come and save me, only nephrostomy. Now we go to the fans. Fans is a standard, so it's always there is a force, there is injury into the ureter, so it's about your force when you insert. Otherwise, you'll split the ureters to two parts. Again, fans is good. I started 6 years ago. Now I have so much critics about the fans. Now you can see that you are putting a 12 French inside the junction. Junction is very small, very restricted. And we are trying to teach the people to go with the fans to the lower calyx. You are twisting, you are hurting the junction. Look at these junctions. Look at this with the fans, twisted ureters, twisted junction, and the other one is traumatized because of too much manipulation. I start to stop the fans at the beginning of the proximal ureter, finish the job, then I try to suction. But I was so fan about the fans. But now it came down to me that I have to think about the size. We have to think about this. Nobody will report these cases. Look at this fans, movable, expandable, bendable urethral access sheet. Look at the junction, very ugly space. We don't report these things. We need to think that, okay, so I asked many colleagues, do you have these problems? They said no. So I start to shift myself to 6.3 and 8, 10 access sheets. And I said 10 French is a little bit better than the 11 or 12 French. So think about it. I think with the time you will discover yourself vision about this. But as been 6 years with the fans, I think we have to revise ourselves about it. And we have two strictures now. I will show you the pictures. Now this is the fans. When Lorian, he told that you can slide the fan, and remember the fans has a tip flexible. If you slide it on 6.3, it will bend because it's a bendable, and the tip is a floppy, so it will create like a knife. So if you don't take care, it will cut the ureter. So do not insert the fans big size over a small scope. And this is the problem. You need the space to finish the job, but you will have this problem. You will figure it out with the experience, because I think you more learn with the working. Putting an access sheet penetrating the kidney because you work without X-ray, or you putting the access sheet behind the renal papilla. You can see this is the hilum there. This is the outside the renal pelvis. And access sheet is not only about the urethra and the kidney. If you force it, you might injure the urethra. And this is about the force that we apply. So we have to teach our resident that you have to feel. That's the problem. We see only images and we see the operations. Excrucian, you have to make sure that the stone, there is nothing in the ureter. Do a retrograde, do a semi-rigid, explore the ureter, or you will push the stone outside by an access sheet of the material. Look, then you will get in trouble to take this stone out or leave it there, and will cause a stricture. So always be vigilant with the flexible ureteroscope. With ureteroscopy is not anymore safe. You have to see these things. Baskets everywhere, or pulling the basket, pulling the stone, pulling the ureter out. You want to get the fragments outside your sensitivity, but I don't know about the future of these ureters. So look at this, no guide wire, no visual estimation. I call it visual estimation. It does not come with the reading books or seeing videos. It comes with the work and proper visual estimation. I don't know about the AI now, can tell you which size you can retrieve the stone, but eventually basket is dangerous sometime. This ureter, you want to pull it.
For sure.
Then you'll see this ureter comes inside the access sheet. And this will create the problems like I have seen this in France when I was in Paris. I saw this case, which is interception of the ureter. A Senegal guy, Lebanese, living in Dakar, and we saw this, and I asked him, they did 6 uteroscopy with the basketing. This patient, we published him, and they replaced him with the ileal replacement. Now, we figure out this is a junction, multiple operation, and then multiple URS for UPG structure, cause we don't know. We have to think wisely about it. This is a 5 millimeter stone in the upper calyx, in the upper ureter. The patient lost the follow-up. She came with destroyed kidney, DMSA 6%. The message here, you have to see your patient. I asked the urologist what happened. He said, it's a very simple uteroscopy. I removed the stent after 2 weeks. But she came after 1 year with a kidney atrophied. Follow up your patient, please. We have to know that the strictures, we have 1 out of 4 patients will go for nephrectomy and 2 will suffer for life and 1 might escape. 25% of the uterine stricture will have a nephrectomy. Now, the pressure. Pressure is important. This is the subject with the section nowadays in endourology. Your rupture fornix having in high pressure. Look at this explosion of the ureter. And again, same picture, venography, because too much high pressure, and you can apply. This is the cracks, bleeding, happening because of the pressure. Time, right? And this looks like a bleeding because of the kidney crying, so comes the clots outside, and you can see how much the kidney is a very soft organ, or you can see them cracks after you finishing the stone, all the cracks and the fat coming inside the kidney. This is a complete crack of the mucosa. And this is a patient of 2 centimeter stone. You can see the whole crack in the system. That picture is early of the uteroscopy, but this one is a complete crack of the renal pelvis because of the pressure. You can clearly see in this. So do not think that I will use an access sheet. This is a patient, subcapsular hematoma with too much pressure. 2 years, look at the hematoma, the stone outside, outside the kidney, then the kidney was removed 2 years because of the atrophied kidney. Blood clots, you have to take the patients, take the clots out. Retain materials, guide wires, baskets, 15 years, 10 years. That's a hydrophilic after uteroscopy coating for 5 years. So examine your material, make sure that your guide wires are intact. Some nurses will just throw them, do not look for them. And of course, broken fibers, this is from Traxer, and double G stent inside the kidney. Make sure that you remove the totality of the double G stent, not only the part of it. This is a famous publication in Canadian Journal of Urology by Professor Traxer. I found this, then I told myself, what is this? So it's a patient with conservative treatment, so we removed it. I removed it with Philips Ebb. So it was amazing that, what is this? Now we come to the access sheet. I remember that the question was during the discussion, these access sheet fans are very soft. It might be broken, so do not reuse them. Look at this access sheet, left in the ureter, complete in the ureter without guide wire passing, so you have to solve this problem. This access sheet cannot be used multiple times. You have to respect them. Look at the wires all in the ureter, so solve it. We have to take the kidney, you go antigrade, you go whatever, but you have to solve your problem because you are using defected material or untrusted material. Access sheet eventually went out because we were lucky, we pulled it. So three patients, 4 patients left with the broken fans inside the ureter, especially with the virgin ureter, because it's closed on the access sheet and you cannot retrieve it, and the tip is very soft. We are happy that, you need a softer because I want to go to the lower calyx. But you forget about this because you have to work more and more and discover the downfalls of this instrumentation. Access sheet is stuck. You have to find the solution, escape plan. You inject xylocaine gel, you do whatever, but you will be in trouble because this access sheet can cause injury. Look at this. Look at the whitish ureter. Too much pressure in the ureter. Again, hydrophilic coating. Some hydrophilic coating bad industrial. They put you hydrophilic coating left into the ureter. Again, This is a hydrophilic coating left in the ureter. We did not figure how do we solve it. Some people suggested for me put iodine and put contrast, but I told myself I'll leave it. So I followed those patients for almost 24 months and they went fine. But I don't know if anything happened to you guys or in China or anyone, something like that. Despite this is not reused access sheath. Again, I found this piece. I told myself this patient came because of the stone. When I went in, I thought this is a calcium oxalate with a uric acid. So when I pulled it out, I found the tip of the scope. Then I published it. The company called me. They said, you have to remove your publication. So I said, no, this must be reported. Yes, I'm honest. So I told them there is no way. So I published it. And because they know the tip, I said, okay, there is something wrong. So I discovered that sometime using material, money, you know that the scopes are fragile. You cannot leave them inside. So do not compromise the safety with the cost. Now, examine your material after and before, and stop using defected material. Look at this access sheet used. I took this video from a friend, then I saw this access sheet. I said, this access sheet must be used 50 times. You cannot put such a tip of access sheet inside the ureter without injury. It's crazy. So stop endless reusing disposable. I don't mind to reuse it maybe once, but endless reusing, this is very bad. And Benjamin Franklin, he said, the bitterness of poor quality remains long after the sweetness of low price is forgotten. And this is a very important message to the young people. This is publication I did with Professor Traxler when he taught me 2010, 2009, when he said it is essential to know available material and devices in order to respect the patient anatomy by adapting the equipment to the patient, not the reverse. So if you have a scope, 12 French, oh, I have this, it will fit all my patients. Now you have to develop yourself and develop your material and go smaller, change your habits, and this will go fine with you. Plan it well. As we saw the first CT scan, plan it well. Is this stone can be achievable by flexible? If you plan it well, you have to do it good. Go smaller with instrumentation. Limit your operative time. As I said, Professor Alkin, he said 3 hours, 4 hours during this operation. If it doesn't not allow you, do not force. If difficulty, terminate and run. Learning curves in details, explore the ureter always postoperatively. Prevention is essential, as I said in the second slide. Use instruments and tools properly and wisely and ask the experts, is this a good instrument or not? We might be happy in the first years, then it might be catastrophic afterward. Do not insult more. If you find any difficulties, run. Put a double G stand run, and do not hesitate to call your seniors. Thank you very much.
So, yeah. Breathtaking. And the last take-home message, don't violate the schedule so badly. Thank you. Unfortunately, we don't have time for the questions.
So we continue with the last presentation from another living legend, Professor Olivier Traxler. He will be talking about next generation RARS, combining suction and pressure control to achieve complete stone clearance. Professor.
So it's our honor to present Professor Traxler, the man who inspired me and many of us to do endourology. So the floor is yours, Professor.
Thank you, guys. Good morning, everyone. First, I would like really to say a big thank you to Asim John and to Lauriane Dragos to build this amazing meeting. I must say that I'm very impressed. I was thinking it's a small workshop with maybe 40 people. So I'm very impressed. Thank you also for the live surgery this morning. Just to keep you informed about what we did, we went into the kidney. We proceed with the full dusting, I would say tiny fragments. The holmium laser was not working very well. We check at the end, some technical problem. And then we were using the fans. And with the fans, we aspirate the fragments. I'm not completely sure I was able to aspirate all the fragments from the kidney, to be completely honest. Most of them, probably. But we spent a long time into the ureter to aspirate all the fragments. We went into the ureter, in and out, probably 60, 70 times to aspirate all the fragments. But at the end, the ureter was completely clean. So it took 2 hours, 30 minutes, a bit too long, 30, 40 minutes, maybe a little bit too long, but it was the case. Okay, so today I would like to talk with you regarding this suction concept and also regarding these new endoscopes. And it's very special for me because at the end of my presentation, I will show you what we develop actually as a new endoscope. And just to let you know that 2 years ago, we did the first clinical evaluation in Tashkent in Uzbekistan, so it's very special for me to show you that. My conflict, I'm also the chair of the new section of endourology. I'm very fortunate for that. You recognize probably many people, and Lauriane is in this picture. So regarding this new ureteroscope with suction, the question is, what do we know actually regarding suction? What do we have in terms of suction concept? And what do we want really? First, we need to keep in mind that when we are treating stones, we are supposed to make the patient stone-free. So it means remove all the fragments. We have different definitions regarding stone-free actually, but at the end, we would like to remove all the fragments. If we ask urologists what is the technique they prefer when they do flexible ureteroscopy, more than 2/3 of the people said we prefer to go for full dusting. Probably because it's relatively easier, it's maybe less time consuming to fragment the stone in tiny particles without doing this basketing. We also know that if we're able to produce very tiny dust, the dust evacuates because the dust is floating and most of the dust evacuates during the surgery, but also post-operatively. Only the tiny fragments will stay into the kidney, and we know that because when we do 2 sessions, after the first session, the kidney is full of dust and tiny fragments, but when we are back for the second session after 1 or 2 weeks, the dust disappears. Just the tiny fragments stay into the kidney. So what are the problems actually if we are talking about flexible ureteroscopy? The limitations. The stone-free rate, that's the main problem. We are not able to make all the patients stone-free. We need to be honest. We are not as good as we are thinking. The problem is high temperature because we are using more powerful laser, and the last problem is this problem regarding the pressure. If we try to irrigate much more, we increase the pressure, and you know the problem associated with pressure. So if we are thinking about those problems, what is the solution? Solution is unique, it's suction. If we are able to design a good suction system, we will solve all the problem. Patient will be stone-free, we'll have no problem regarding the pressure because we can regulate, and we will have no problem regarding the thermal damage. Problem is suction. What would we like to aspirate? We need to have a clear definition of what we would like to aspirate. If you would like to aspirate 1 millimeter fragments, then you will have to design something relatively big. So since we have to use small instruments to respect the anatomy, we need to put some limits in terms of size of the fragments we would like to aspirate to design a specific system. But we have no clear definition of dust. Who knows what is dust? So in my lab, in Paris, in Sorbonne, since we were doing some experiment, we were forced to make a definition with dust. And for us, what is the dust? Dust is particle less than 250 microns. Why? Because if you consider a working channel 3.6 Charrière, you can aspirate less than 250 micron particles with no blockage. If you have particles bigger than 250, you will experience some blockage into the working channel. So that's the reason why, for me, for my team in Paris, dust is particles less than 250. The second question is, okay, now we know what we would like to aspirate, less than 2, but do we have technology to produce less than 250 micron for any type of stones? The answer is yes, thulium fiber. And that's the reason why we love thulium fiber, actually, just because this is the best technology to produce tiny, tiny pieces that we can aspirate. So looking at this concept, you know that we have plenty of publications, starting 2016, talking about dusting and suctioning. So what do we have? If we are looking about the different concept, the fans, you know, is the most common concept actually, probably the most efficient one, not perfect, not totally perfect, but this is probably the best equipment actually if we would like to aspirate. We can also use a regular endoscope, and that's what we call the DIS, coming from the Indian colleague. But the DIS also, we have some limitation. And we have different concept with not the fan, it's not the DIS, it's something more in between. Regarding the fans, you know it's coming from China, from the Chinese colleague. Originally, it was a rigid fan to aspirate fragments from the ureter. And then we have seen this evolution in 2022 with the flexible, so that's the real fans, flexible and navigable access sheath, again designed by the Chinese colleague. If we look at the outcomes regarding the fans, it's true that it seems it improved actually the stone-free rate, but as Said said, we still have problems in terms of accessibility, in terms of safety. We have actually more than 140 publications regarding the fans. The level of evidence-based medicine is really low, actually, so we still need to evaluate this technology. But again, actually in 2026, it seems to be the best equipment. Regarding the DIS, so the DIS came from India. It was designed at the beginning using regular endoscope. Again, very difficult to demonstrate that the DIS improve what we are doing with regular endoscope. You know the concept, huh? You are using the regular working channel, so you can irrigate or you can aspirate. You cannot have a circulating irrigation with aspiration at the same time. Now it's commercially available. Huh? This is probably the most common one, 7.5 with 3.6 or working channel to aspirate. It's very common. What is the limitation of this one? The blockage, again, if you are using a big, if you aspirate big fragments. And it was clearly demonstrated by a Cleman team that if you try to aspirate more than 250 micron, you will experience this kind of blockage. So the second generation is much bigger, 9.2. The working channel is 5.1. But again, if you evaluate that, you will also experience blockage with this new type with big channel for bigger pieces. But again, exactly the same problem. So it seems it's not ideal. In between the fans and the DIS, we have this kind of system. I think that's the best example. This is the CAEC, first generation. Totally blind, and now the CAEC second generation incorporates CMOS sensor to have a visualization. So it's something in between an endoscope and fans. You know also this kind of problem, absolutely no control regarding intrarenal pressure. So if you don't control the pressure when you irrigate and aspirate, you can produce terrible complications like it was already reported. So if we check actually the different systems, do we have something ideal actually to aspirate? The answer is no. We have new concept, it helps, but nothing very optimal. Now we understood the concept to irrigate and to aspirate based on the intrarenal pressure. It seems very simple to say, but I must say that it took some time that the people realized that if we aspirate, we need to aspirate based on the intrarenal pressure. So we have new system actually coming to control the intrarenal pressure just to regulate the inflow and the outflow. And this is this concept. this quadrifecta concept regarding suction, irrigation, intrarenal pressure, also intrarenal temperature. But in fact, the concept, the real concept of suction, it's even more complex than the quadrifecta. We need to design actually something that I will call the ultimate solution. And we published recently this general concept. What does it mean? The system must be a special endoscope. Why? Because with a special endoscope, we need vision. We need to manipulate the instruments into the kidney to go everywhere. We need to have an ureteral access to go into the kidney. So only endoscopes can give this ureteral access. And we need to respect the anatomy. As Said said, so less than 10 French, if we consider that the normal anatomy average is less than 10 French. The system should integrate an irrigation and aspiration based on the intrarenal pressure. Otherwise, it's impossible to regulate inflow, outflow. The system should integrate laser. Otherwise, you cannot produce the dust. And probably we need to incorporate some thulium fiber technology if we would like to produce very tiny pieces. And this is probably the most tricky part of this system, the system should also detect automatically a blockage of fragments into the working channel. And if the system detects the blockage, the system should automatically unblock, because by yourself, you will not recognize the blockage and you will not be able to unblock the system. And we can also imagine some automatic control to regulate the system in terms of laser settings, not to have too much power regarding the thermal damage, but also to regulate the pressure for inflow and outflow. So you see, very complex, very simple to describe, not so easy to design. So if we look at these criteria, if we check what we have already, the fans, the disc, the CVAC, other system, there is no system actually who fits with this concept in 10 points. It doesn't exist. I would say not yet, because that's what we actually design with this IPG company. So the concept of suction, it's not only a negative pressure and a tube to aspirate, it's an endoscope, it's a laser technology and irrigation and aspiration. If we would like to summarize, it means visualization, energy, and fluid management at the same time. And all the three different parts should communicate together. And probably with some automatic control, we can call artificial intelligence. It's in fact system to automatically control. And this is the system that we design, actually with IPG Photonics. And so it's an integrated solution with fluid management and suction with pressure control. This is the concept. You see coming from the lab, and that's the lab experiment that we did with IPG. You see immediately the benefit to have aspiration and irrigation at the same time compared to what we do today with only irrigation. So we did the first clinical trial in Tashkent, Uzbekistan, in the same clinic than this morning in 2024. And we operate 12 patients with this new endoscope. This endoscope is a 9 French endoscope, so it means that it respects the anatomy. And just to show you some example, you see on the left at the beginning when the stone is really big, so you do exactly the same job you are doing with a regular endoscope. You are producing this dust. You see the setting we were using, 25 watts. We try to not to put too much power regarding the possible problem with the laser, the thermal damage, but it was really, really efficient. You need to consider that we have a circulating system to irrigate. We irrigate and we aspirate at the same time. And you see at the end, when we have this popcorning phase, that all the fragments are coming to the tip of the endoscope. We are not chasing the fragments as we do today. That's completely the opposite. Due to the turbulences that we create with the irrigation, you see that all the fragments are going to the tip, tip of the laser fiber. You just have to stay in front, don't move, wait for the fragments coming to the tip. So very easy to manipulate. It's even easier compared to the regular manipulation of a standard endoscope. And just to show you some other example, you see at the end, we have plenty of fragments. You just stay in the middle, okay? Don't move. Activate the system together with the laser, and you see that all the fragments are coming and will be completely aspirate. You will see even we are making some pause. You see that fragments are coming, and all of them are completely and fully aspirate into the working channel, keeping the pressure completely constant. Also, this kind of small debris that you know very well, something not so easy to aspirate today with a regular endoscope, but with this new system, it was able really to clean all the different particles. You see the 12 patients, that's what we aspirate at the end. With the stone catcher, we have all the dust, and you see the quality of the dust that we aspirate. And if you look at the stone volume at the beginning that we calculate with a CT scan, if we compare what we aspirate, it was 100%, very close to 100%. Why not 100% for some patients? Just because tiny fragments evacuate also into the bladder. So that's why you have this minimal difference between the pre-op stone volume and the post-op. Just to show you an example, so this patient underwent a PCNL, and you see all the big residual pieces in different calyces. You see the nephrostomy tube in yellow. We did this case. The total stone burden was 5,300 cubic millimeter. What does it mean? It means a stone of 2 centimeter, a real 2 centimeter one, plus an additional 13 millimeter, just to simulate the total volume. And this is the results just the day after the surgery. You see on the CT scan, completely stone-free. When we evaluate the 12 patients with post-op CT day 1, we demonstrate 100% stone-free rate at day 1 with no complication with this initial trial. Artificial intelligence, what can we imagine actually associate with this kind of system? Another technology developed by IPG that you probably know is the stone sense. What does it mean? It means that when the laser is active, the laser itself recognizes the tissue from the stone. So when you activate the laser, if you are in front of the tissue, the laser stops. If you are on the stone, the laser stays on. That's what we call the stone sense. So it's an automatic control. The system detects the stone or the tissue, but the system also detects if you are too far from the stone. You are in front of the stone, but if you are more than 2 millimeters, the laser will not be active. It means that the laser is only active if you are in the right position to treat the stone. So that's something, again, that it was communicated and published. And you see the difference between the stone sense or no stone sense regarding the benefit regarding the mucosa, and you can immediately imagine the situation where this kind of system is very useful. This is the ureter, to protect from the damage from the ureter. How does it work? You illuminate with regular endoscope the tissue and the stone. The reflecting light is coming back through the laser fiber, going to the laser unit. Into the laser unit, you have an analyzer able to recognize if it's the tissue or the stone. If it's the stone, it's still active. If it's the tissue, the system stops immediately. Regarding the time reactions, 40 times faster compared to the human reaction. So it's much, much better than what we can do by ourselves. So all this concept with this new scope based on the pressure for irrigation aspiration with the laser integrate will be probably the next step in terms of suction concept to be better, to make the procedure easier, safer, and faster. If you would like to learn more, I can just invite you to come to Valencia, to the ICE meeting, 8 to 10 October. You can be sure that we will have more data to present. Thank you.
Thank you very much. Thank you very much. Unfortunately, we have to move on and, urgently wrapping up this section. And the important information is about that, according that I was instructed with, we meet here in 40 minutes, something like 2:30. Yes? Okay, so this section is closed. Thank you very much for your attention.
Ladies and gentlemen, we are now breaking for lunch. Please enjoy the break, and we look forward to continuing the program shortly. Thank you. Ladies and gentlemen, we are now breaking for lunch. Please enjoy the break, and we look forward to continuing the program shortly. Thank you.